Test, 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 test. 1, 2, 1, 2, 3, 4, 1, 2, 3, 4. Test, test, 1, 2, 1, 2. Good morning, good morning. Hello, welcome. We're now we are now about to begin the Sunday session. If we could turn the audio down a little. Thank you. Yeah, we are now about to begin the Sunday session. Yesterday's session was primarily research, and today's session will be the clinical dimension of FSHD. We are a little bit behind schedule. I'd like to call the morning panelists that will have 4 talks, great questions, 3 talks, great questions, and then lunch. I'd like, as a housekeeping announcement, I'd like to let you know that today we have coffee and tea earlier, and coffee and tea is now outside for those of you who wish to have coffee and tea. And then we will serve lunch at lunchtime. I'd like to call the morning panelists up. So Dr. Statlin, Dr. Wagner, Dr. Sacconi, and Dr. Van Engelen. I was wondering if you would kindly make your way to the front of the room. We'll begin today's session. Dr. Sacconi is, okay, Dr. Sacconi, I think, will join us. We begin today's session. It's an honor to have, firstly, it's an honor to have these physicians here today, world-renowned, world-class doctors, medical doctors, and medical researchers working on our disease from major centers, from the major centers from all over the world. And the pedigree of these individuals is extraordinary, and then also their commitment to their work and the patients. And it's just, I can tell you what an honor it is to have these individuals with us today. I'd like to begin with Dr. Jeffrey Statlin. And Dr. Statlin just recently moved from the University of Rochester, New York, to Kansas City, to the Kansas University Medical Center. Dr. Statlin will be talking today about opening the clinical trial toolbox, and it's an honor and a privilege to introduce Dr. Statlin. Thank you.
Thank you very much.
I just read it writing a little bit. It's
I want to thank the FSH Society for giving me the opportunity to come speak to you today at what I think is a very exciting time in FSHD research. Recent molecular advances have proposed a unified genetic hypothesis for FSHD types 1 and 2 and have identified some potential therapeutic targets for clinical trials. This has brought a lot of excitement to the field for individual researchers, but also drug companies thinking about developing new drugs for FSHD. Hand in hand with the advancements that they're making in the clinic comes the need for us as an FSH research community to develop the tools, the outcome measures that we're going to use to measure a response to therapy in the setting of a clinical trial. So this is what I want to talk to you a little bit about today. What are outcome measures? How do we match them to the stage of drug development that we're at? And what are some of the outcome measures that we've used in FSHD? So an outcome measure is a tool that can measure any aspect of the disease. It can measure something in your blood. It can measure some aspect about your muscle. It can measure questions about your quality of life or how you're doing. But I think the key word here is a measurement. It's some sort of number, some sort of metric that we can follow to determine if time A is different than time B, if some essential change has happened in the disease process. It's for use in clinical trials, but we can also use these in clinic. Ideally, outcome measures should be pertinent to FSHD. So we'd like it to be measuring something that's either important to the patient or that clinicians have identified as being important to the pathological mechanism of the disease. We'd like outcome measures to be reliable. So if the disease isn't changing, we'd like what we measure to be the same from one day to the next. But we also want these measures to be sensitive. So if the disease is changing, we'd like the outcome measure to be able to detect that change in a proportionate fashion. We'd like them to be inexpensive. This gets to the feasibility of running clinical trials. If your outcome measures are outrageously expensive, it becomes very difficult practically to make a clinical trial happen. And then we'd like them to be collected at multiple sites in the same way. This standardization of protocols and the ability to collect similar information at different sites is really key to building the infrastructure to run clinical trials. So the right tool for the right job. So we'd like our outcome measures to measure some aspect of a disease that we're interested in following. For example, measuring gene expression's not really going to tell us a lot about whether someone's experiencing pain. We need different tools that will be important at different times in the drug development process. So we're really not talking about one outcome measure that's going to be the be-all and end-all for FSHD. We're really talking about a whole set of different outcome measures that will have their role at different points in the drug development process. So matching the outcome measure to the study aim. So this has a little bit to do with where you are in the drug development process. So when you're doing early studies, these are typically short studies in smaller numbers of patients, and they're often looking at questions like safety and dosing. For these studies, biomarkers become very important as proof of concept or early markers that your drug's doing what it's supposed to do. Things like strength measurements or functional outcome measures are important as you get into this question of effectiveness. These sort of mid-stage studies, they're typically longer in duration. They often require more people. And these are really the go, no-go studies. The studies where we say, do we have enough information here to think we're ready to go on to the large studies to get approval to market a drug in the United States from the FDA or in the international communities from the respective regulatory bodies. And then patient-reported and quality of life outcome measures. These become increasingly important as a drug moves through the process, and they really judge the overall impact of a treatment on both the physical and the mental aspects of a disease. So biomarkers, as the name implies, it's something that you measure in blood or tissue. It can be gene expression, it can be protein levels. Other measurements like neuroimaging, and I'll get into this a little bit, can also serve indirectly as a biomarker. They're important for these early studies, where small numbers of people, where you really want an initial signal that a drug's doing what you think it's going to do. And also for proof of concept. If the idea is that a drug is going to turn off protein A, you'd like to be able to measure protein A and show that it's being turned off. Ideally, we'd like a change in these biomarkers to predict some change that occurs later on in the course of the disease that's important to people. For example, predicting whether or not you'll need to use a cane or a walker at a future point in time. But they don't have to have that tie in order to still be useful. So what are the biomarkers that we have for FSHD? Well, DUX4, the protein you heard a lot about, I think, yesterday, well, this might be an ideal biomarker, but it's very difficult to measure directly in patient tissues. The background to this slide is an image from the Tapscott lab, and I like it a lot because it shows a string of nuclei from a muscle culture in the background, and that pink color is DUX4 being expressed. But short of measuring DUX4, other genes affected by DUX4 or downstream from it may be more persistent, and these may actually serve as really valuable biomarkers for early studies. Other proteins in your blood or serum may be also important, either related to the disease mechanism or indirectly related. Proteins that may be show you indications of muscle turnover or oxidative stress. However, more work's needed to determine which biomarkers are going to be important in FSHD, and it may be that different biomarkers will be important for different types of drugs. So it may be partially determined on what kind of drug you're measuring. MRI may serve as a novel, non-invasive biomarker of disease progression. MRI uses magnetic fields and radio waves to take advantage of certain quantum properties of water molecules to get us really sophisticated information about the structure of muscles. There's been some indication in FSHD that changes on MRI may give us some signs of disease activity in FSHD. And an ability to target some muscles that are at risk for progression. The picture that you see here on the screen is from an Italian study, and under the label T1, what you see is the arrow pointing at a muscle that really essentially looks normal on that MRI sequence. Underneath the T2 stir label, what you see is that same muscle shows up bright white. And in this Italian study, they biopsied these bright white muscles, and what they found was inflammation. In a certain number of the muscles, they found some molecular markers that there was disease activity related to FSHD in these muscles. So this MRI stir sequence may give us a way to identify muscles that are at risk for progressing, and also a way to monitor a response to therapy. Another aspect of MRI that might be very useful in clinical trials is quantitative measurement of the fat in the muscle. This is more and more becoming used in different types of muscle diseases. We see it being used in the limb-girdle muscular dystrophies and Duchenne muscular dystrophy. And what I'm showing you here on the right in that figure is some data taken from a study that was completed in the Netherlands that I think you may hear a little more about later. But what it shows is on the y-axis is the ratio of fat inside a given muscle. Each of those little circles is an individual muscle that was measured. And what you can see in that graph is along the bottom, there's a whole lot of muscles that are essentially normal. They have a very low or almost no fat content in them. On the top of the graph, what you see is there's a lot of muscles that are really almost completely replaced by fat. So these would be muscles that are already, very weak, far along in the process. But what was most interesting was this intermediate group of muscles, these muscles with an intermediate fat content, because what they found is they were most likely to progress to change over a very short period of time of 3 months. So that means measuring the quantitative fat may be a very effective way to get an early signal that a drug is doing something in a muscle that might be useful to follow. So the workhorse for clinical trials in muscular dystrophy has really been measuring strength. Strength would intuitively seem very meaningful in a disease that's primarily affecting the muscle. There are 2 very well-studied methods for measuring strength in FSHD. One of these is manual muscle testing. The other is quantitative myometry. And many of you in here will have had one or the other done on you at one point in time. Both of these techniques test strength against fixed resistance or isometric contractions of the muscle. Quantitative myometry uses a digital force transducer. This is the quantitative part. And what you can see in this picture is an example of the common apparatus for this, which is a table that has a large metal frame around it. And the force transducer is connected to an inelastic strap, and a person's put in a position to isolate the strength of a single muscle. So there's standardized positions for doing this. You can also use handheld strength gauges to do this. Manual muscle testing, on the other hand, tests your ability to pull or push against an evaluator who's been trained in standardized positions and procedures and has been trained in using a standard strength scale that ranges really from normal strength to no strength at all, where somewhere in the middle is the ability to contract that muscle against gravity but not against resistance. So both of these methods have proven to be reliable. And you can average muscles across multiple muscle groups to get a combined score that you can think of as the average overall strength of an individual, which you can follow over time. The data in this graph is from one of the longest natural history studies in FSHD, and it shows you a change in strength on the y-axis, months of follow-up on the x-axis. People came in every 6 months. Each of the plus signs is an individual. The dotted line at 0 would be the change in strength compared to the first visit. So if you stayed at that 0 level, that would mean your strength wasn't changing at all. And what I really want you to look at is that second group there, because that would be 1 year of follow-up. And there's a couple things I want to point out. First of all, the length of that line, it's quite long. So there's a lot of variability from individual to individual in the changes in strength. There's some individuals above the dotted line. These would be people who got stronger over the course of a year. And there's individuals below the line. These are people who would get weaker over the course of the year. The X is the average change in strength. And so what we saw is, as a group, people lost about 3 to 5% of their strength over that year. However, small changes in strength can be very difficult to put into a clinical context. What does it mean to lose 3% of your strength? And that gets to this idea of functional outcome measures. These are things like the time to go up some stairs, or to walk a given distance, or to lift objects over the head. The FDA is really interested in these outcomes because intuitively it seems like activities that correlate to things that you do in everyday life would be meaningful. In FSHD, we've looked at a number of these, and they show moderate to strong relationships to disease severity or measures of strength. But when you look at populations of individuals, we don't really see them changing over time. And this is time periods up to 3 years of following people. That doesn't mean that for a single individual, they wouldn't have had a significant change in one of these tasks, but in groups of individuals, it's very hard to document a change. Patient-reported outcomes can be standardized questionnaires. Some of these aren't disease-specific at all. Some of you may have heard of the SF-36. It's probably the most common quality of life outcome measure used in clinical trials. The SF stands for short form, the 36 for the number of questions. It asks you questions about your physical health and the impact of your physical condition on your mental health. The Promise 57 is a version of this kind of a form that was developed by the NIH and has the distinct advantage of being freely available. The INQUAL is a little different because it's a little more specific to neuromuscular diseases. All of these scales have been validated and are really ready to go for clinical trials. There is one scale that's being developed by a collaborator of mine at the University of Rochester that's an FSHD-specific health inventory. And the way he did this was he started with patient interviews and determined domains or areas that were important to patients to develop the scale. And in the box, you can see some of these areas that range from problems with the shoulders, with mobility and walking, but also things like fatigue and pain and the change in body image due to the disease. Now, I'm running a little short on time, so I may skip this slide or just go over it briefly. There are a lot of outcomes in development. In fact, as many researchers as there are who have an idea about what would be good to measure in FSHD, there may be that many outcomes, but at a certain point, it's important that the procedures and the equipment for measuring these outcomes become standardized. The 3 that I've put on this slide, I think, are reaching that point where they're getting close to being able to be used in development. And these are electrical impedance myography, and I want to mention it here because the FSH Society has been kind enough to support me in collecting data on this outcome. Reachable workspace, which uses a very novel 3D camera system that you can get with the Xbox Connect to discover how much space someone can reach with their shoulders. And MRIS, this is a different aspect of magnetic resonance imaging where instead of looking at the structure, they're really looking at metabolites in muscles. If anyone has questions about these, please feel free to ask me after the talk. So how many people are enough? This really depends on the outcomes variability, the variability across individuals, and the variability within a given individual, and how big of effect. The smaller the variability or the larger the effect, the fewer number of people that will be required to do this. A better understanding of our outcomes can help us plan trials more efficiently. And I just want to conclude on this notion about coordination between sites. In the end, we're a community, and we're going to come up with these outcomes together. The ability to standardize protocols so all of us who are looking at the same thing are collecting them in the same fashion will help us build a network of sites that are ready to run the clinical trials. So we'll be ready to go. Thank you very much for your time.
Thank you. Thank you. Our next speaker, first I'd like to preface with there's extraordinary work going on all over the world, in the Netherlands and in France and in England and Australia, and these countries, they have particular characteristics, particular strengths, excellence in research as well as the United States. France, I mean, we've heard from the folks in the Netherlands, and we will again, but I also wanted to say that the researchers and clinicians in France are doing an extraordinary job in terms of large-scale infrastructure on the government level and also on the Association Française contre les Myopathies, the AFM, the French Muscular Dystrophy Association, who is sponsoring the meeting today and has always been a generous sponsor of these kind of activities. The French are just a really outstanding group of researchers, I think often overlooked in the collection of FSHD research. And so, I mean, with that, I want to say and it is in Nice and Montpellier and Paris. And so with that, I'd like to introduce Dr. Sabrina Sacconi from the University of Nice, France. And Dr. Sacconi will talk about the advances in the care of FSHD, and thank you.
Thank you very much to have invited me to talk about these advances in care of FSHD. To try to summarize these advances and also to present you the work that we have done in the last year, I would like to present you some data about the French National FSHD Registry that was launched 1 year ago, and that is founded by the AFM, the French Association Against Myopathy, with the aim of collecting epidemiological data to promote clinical research and to develop a standard of care for FSHD patients, and also to try to validate outcome measure in a natural history study, and to facilitate recruitment, future recruitment of patients in a clinical trial. The data of this registry has been established in agreement with items of pre-existing registry, like the one in Rochester, the Italian registry, and the Netherlands registry, and to enable future international registry harmonization. And there is a dedicated database and website that has been developed to enable online data input. The data content is related to the genetic diagnosis, muscular and extramuscular involvement, as for example, the ocular involvement, respiratory, cardiac, gastrointestinal, the hearing loss. We speak about all this type of involvement today, but also some other information like central nervous system involvement and endocrinological involvement and metabolic involvement. Some of these involvement are comorbidity that can be present in FSHD patient, and they may change the interpretation of data. We also collect data on pain and fatigue and patient care, but I will not talk about this because some other people will do. The patients that are included in the registry are genetically confirmed FSHD1 patient, but also genetically confirmed FSHD2 patient. The patient may enter the registry by filling a self-reported form or a clinical evaluation form. FSHD2 patient may only enter the registry by a clinical evaluation form. We collected data of about 300 patients, 143 women and 157 men. You see that the center that contributed most is Nice, because I'm there, and so I'm the one that coordinates this registry, and there is a lot of work to be done again in the next months. The age of the patient included were from 11 to 89. The mean age at the time of the inclusion was 54, and the mean disease duration was 24 years, and the mean age of onset was 34. Most of the patients included are FSHD1, 95%, and only few FSHD2 have been included because the molecular diagnosis for FSHD2 is available since very few months. Talking about genetic data, we have 31 patients included that carry from 1 to 3 repeat on chromosome 4, 153 patients from 4 to 7, and 104 patients from 8 to 10. If we talk about genotype-phenotype correlation, we found a nice correlation between number of repeat and severity of clinical phenotype, although with some exception. This patient here have from 1 to 3 repeat, and they have a very early, a very late age of onset, because they were supposed to be affected since childhood, but they are not. They have a late onset. But when we look closely to this patient, 5 of them were mosaic. One patient have a very strange rearrangement between chromosome 4 and chromosome 10, and for one patient we couldn't find any explanation about this, the fact that it was less affected than expected. Also, for these 3 patients that carry 4 repeat, we have a very late age of onset. These patients are not mosaic, so there is no explanation. And to identify this type of patient is very important, because maybe we can find something that can be protective, and then in this patient. And then this will be the work of in collaboration with all the people that we collaborate usually, so the Netherlands people, but also maybe some other, to find out what is going on in this patient. On the other side, we have patients that are more affected than expected. These 12 patients have from 7 to 9 repeat, and they have a very early age of onset, and also we will see in the next slide they are all wheelchair bounded, and they have hearing loss and so on. And from 8 of these 12 patients turn out to be FSHD1 plus FSHD2. But we also have 4 other patients in which we don't know why they are so affected. So another gene can be a modifier, or maybe another comorbidity condition can contribute in the fact that they are more affected than expected. So again, it's very interesting to identify this type of patient, because we can learn from this patient many information on genetic and epigenetic in FSHD. It's true that there is an important heterogeneity in clinical presentation, so we can distinguish in infantile onset less than 10 years. The classical onset are described as patients developing the disease before the age of 20, and then I put late onset, patients that develop the disease at more than 20. But when we look at the reported age of onset of our patient, what we find out? We find out that there is an important number of patients developing the disease before the age of 10, and most of these patients are real infantile onset FSHD1, and other patients are FSHD1 plus 2. So if you have a very early onset and you have 7 to 9 repeat, maybe you have to look to other modifier gene. If we look at the number of the patients that started the disease before the age of 20, we see that they are not the majority. The majority is found when you look at patients that started this disease before the age of 40. Why this thing? I think this is because there is an underestimation of the reported age of onset by the patient, because patient doesn't feel sick because they develop the disease very progressively. Facial involvement is not very recognized by the patient, and also shoulder involvement is frequently attributed to other facts than the muscular disease. So they come to our observation when they have lower leg involvement. And if you don't ask with a lot of questions and very specific question to the patient exactly when it started the disease, he will tell you that the disease started when it comes to your attention. And I think that this underestimation is real because when you look at the data in the self-reported form and the data in clinical evaluation, we see that patients tend to underestimate the reported age of onset. And this is very important because we cannot classify patients in base of the age of onset if this age of onset is unreliable. Ocular involvement, we all know that in a few patients, Coats syndrome may be present. What is Coats syndrome? It's an exudative retinitis that dilatation of retinal vessel has been found in many adult FSHD patients, but is frequently asymptomatic. In few patients, this telangiectasia evolve, and exudative retinal detachment is the consequence. In a study that was done in collaboration with Jeffrey Statland, we found that most of the patients that have this retinal detachment were patients carrying 2 repeated units. And the Coats syndrome was frequently associated with neurosensory hearing loss, was frequently asymmetric, and was more frequent in women than in men. So what about the data in the registry? The data in the registry confirm this study because we found 8 patients with Coats syndrome, 7 women and 1 man. In all of them, it was bilateral and asymmetric. 7 have less than 2 repeats. 1 patient was a mosaic, and 1 patient has 4 repeats. But this patient doesn't experience retinal detachment. In 5 patients, telangiectasia was associated to retinal detachment. In 3 patients, this detachment was prevented by laser therapy. And 5 patients have also hearing loss. So this is a very rare condition for FSHD patient, but has to be researched in people with infantile onset disease. This situation is much more frequent. Because 38% of our patients, it means 114 patients over 300 reported, that frequently they have red irritated eyes, burning eyes, excessive tearings. And all these patients presented with a major orbicularis oculi weakness, and 34 patients, so 12% of them, report complication of this weakness, episode of repeated conjunctivitis. And if you look at the distribution, the patients that are more keen to develop this type of problem are patients that are more severely affected. In between patients having 8 to 10 repeat, if we take off patients with the FSHD1 and FSHD2 together, there is no such a problem. This problem may develop in patients carrying 8 to 10 repeat only when they are very old, because age may contribute in aggravating this type of problem. what we can do about it. One possibility is to use artificial drop, but is not very effective. And now we are studying in this another possibility, that is the possibility of surgery. And it's a surgery that is the opposite of the upper eyelid surgery. So basically, you advance the lower eyelid retractor. This one example, we have 2 patients that has been operated, so it's too early to talk about this possibility. But can be maybe in the future an option. What about hearing loss? In our registry, we have very few patients reporting hearing loss. I don't know why. Only 18 patients. 12 of them use an hearing aid. 8 of them have a short repeat size, so it was much more frequent in patients with, again, with infantile onset. And 4 of them develop hearing loss after the age of 70. I think that in this case, these 4 patients have hearing loss not because they have an FSHD, but maybe because they are older. So we have to distinguish when we make study, I think, and we study extramuscular involvement between these 2 types of patient. Respiratory involvement. Again, 25% of patients had respiratory involvement, which is a very high rate of patients. 12% of them, 36 patients, are in non-invasive ventilation. But when we look at the causes of this non-invasive ventilation, we see that 12 patients are in ventilation because of sleep apnea, 21 because they have a restrictive lung disease, and 3 patients have both. When we look at this distribution of respiratory involvement, we see again that infantile onset are the more keen to develop the respiratory involvement, but there were also some patients with late onset and high number of repeat. We try to find out what are the risk factors to develop respiratory involvement. Some are related to the disease, like for example early onset, long disease duration, and wheelchair-bounded patients. There is also an increased number of patients that have respiratory involvement because they have abdominal and axial weakness. The age also is a risk factor, and the weight. Patients that are underweight and overweight seems to be more keen to develop respiratory involvement. There is also the fact that I think that respiratory involvement is overestimated in patients with orbicularis oris weakness because of technical problem in functional respiratory test. So we have to be careful on this point, and I think that when we will revise data, taking in mind this point, we will lower the percentage of respiratory involvement. What about cardiac involvement? Again, we have a very high rate, 70% of patients. But when we look at the patient, we found out that most of these patients were men, and the mean age was 57 years. So only 3 patients were infantile onset FSHD patients, and these patients have a very mild cardiac involvement, consisting in nocturnal episode of sinus tachycardia. In 41 patients, there was risk factor to develop cardiovascular disease, like, for example, elevated blood pressure, overweight, diabetes, hypercholesterolemia, smoke. And most of the cardiac involvement can be explained by this risk factor. 10 have left ventricular hypertrophy that was associated to elevated blood pressure. 9 had ischemic cardiomyopathy. 5 auricular fibrillation. Still, 17 of them have sinus tachycardia. So maybe sinus tachycardia can be something in FSHD, but it's very benign symptoms that can be treated with low doses of beta blockers. I finished talking about dysphagia. Most of you have heard this data yesterday in nutrition. 0.5% of patients have dysphagia. Again, this is a problem that is reported mostly in infantile onset patients. Some of the patients have late onset disease and dysphagia. Again, I think that if we look at the causes of dysphagia, we will find maybe different causes, because late onset dysphagia may be due to the fact that the people are getting old and not by the disease. Most of the patients with dysphagia has facial weakness, and in some of these patients there was weight loss, 70 of them, and in infantile onset patients the weight loss can be really important. For patients that develop aspiration pneumonia, and in 2 patients dysphagia was a major complication because they choked to death. So be careful if you have this type of problem. As I said yesterday, because it can be life-threatening. If you look at dysphagia at weight, we found that people who are underweight are frequently people that has dysphagia, so patients with infantile onset, while classical onset and late onset are more overweight. Underweight is not good because you lose your muscle, and overweight is not good because you may develop comorbidity like cardiac involvement, hypercholesterolemia, and so on. So in conclusion, it's true that there is a very heterogeneous clinical involvement in FSHD that may be explained by genetic and epigenetic factors. But we have also to consider factors as, for example, age of the patient, gender, comorbidity, concurrent therapy, habits. So we have to collect all this data to do a right interpretation. We need maybe a new classification, because we cannot use, for example, the age of onset or only the clinical involvement to classify patients. And it's very important to classify them in the 3 different categories I told you, because of the future clinical trial and because of the fact that this patient may have different type of involvement and different progression. So a lot of work has still to be done. I agree that collaboration is the way to do it. Maybe the fact that we have to put together data on different national registries to create an international registry, and to have enough patients to draw appropriate conclusion on all these issues. I would like to thank all the people in France that participated, and particularly the IFM that founded this project, and the patient FSHD group, the French patient FSHD group, that helped me really a lot to disseminate this project. Thank you very much.
Thank you very much. Thank you. Excellent talk. Thank you. I'd like to introduce our next speaker. I've worked with Dr. Wagner for many years, and it's an honor to introduce a doctor who's so committed to her patients and who wishes to make a change in the lives of patients and therapy. So Dr. Catherine Wagner from the Kennedy Krieger Institute will talk on animal models and progress towards clinical trials. So, thank you.
Thanks, Dan. Good morning. It's wonderful to see so many of you here again this year. And I'd like to start just by thanking you for being here, and also thank the families who participated in the genetic study yesterday. You always show up. I mean, it's one of the things that I say all the time, that you couldn't ask for a better population, a better community. You're always committed, motivated, lining up, and yesterday was no different. Thank you very much. So, yes, I've been asked to speak about animal models and the progress towards clinical trials, and I'm going to start with the bad news, which you already know, that there hasn't been enough progress on clinical trials. And this is a slide showing drug development and the phases that drugs go through in order to reach FDA approval, and the number of years that it takes. And this is where you and I want to be with an FDA-approved drug. And as you heard yesterday, this is where we are. We are in mostly in vitro screening, and there's a hell of a long way from here to there. So when I gave a similar talk in, this would have been in Las Vegas in 2010, at the FSH Society meeting. Prior to giving the talk, I did a search on clinicaltrials.gov, where every clinical trial has to be registered in the US, and a lot of, of international studies also do register. And that showed that despite there being dozens of trials for other muscular dystrophies and other neuromuscular diseases, there were only 3 studies registered for FSH, and one of them was our national registry. And so, you know, this was really shocking to many in the audience, including Alan Brown, a member of the FSHD fan club. And then prior to giving a similar talk in Atlanta, I did a search. And now, you know, there were more than 100 trials for some of the other neuromuscular disorders, and only 5 for FSH. Actually, only 5 studies. Only one of them was a drug study, which Dr. Bellahue talked about yesterday, the antioxidant trial in Europe. So, you know, by that point, people are getting dismayed. And now I did a search prior to coming here, and you know, the list is getting a little bit longer, but this is you know, additive, not exponential, which we would hope. Only 9 studies, 0 drug studies, and you know, that just kind of flabbergasts us. You know, particularly when I did a search this morning, ALS. Actually has a lower prevalence than FSHD. It has 259 studies going on right now compared to 9 FSH. So obviously, that just blows my mind. So what am I going to talk about 2 years from now? Well, in 2 years from now, I think it's possible that we could have a clinical trial on a non-specific treatment to improve weakness. And if you were in Atlanta, I believe it was in Atlanta, Cytokinetics came and talked about their troponin activators, and we're continuing to speak with Cytokinetics. There's a group of people, including Jeff and myself, who have been talking with Cytokinetics about appropriate outcome measures, and I think that is still a possibility. They've done their first clinical trials in ALS and myasthenia gravis. Myostatin inhibitors, I think, is certainly worth another trial in FSH muscular dystrophy. As many of you know, there was a trial with a drug, a neutralizing antibody to myostatin by Wyeth. The name of the drug was Myo29, and that had many different types of adult muscular dystrophy. This was, I don't know, maybe 7 years ago now, and there were consistent positive trends in the FSH subgroup, but there were too few in the higher dose group to really say anything conclusively. And many companies now have interesting myostatin inhibitors. And between Dan and I, we've probably talked to all of them and encouraged them to look at FSH muscular dystrophy. Novartis has an interesting drug. The global head of muscle research, David Glass, is on the advisory board of the FSH Society, so we'll have to ask him why the first trial with his myostatin inhibitor is not in FSH, but in inclusion body myositis. And usually the response to why not FSH has been, well, we don't understand the pathophysiology, we don't have the animal models, but clearly that's not true, because the first disease population for the Novartis drug was inclusion body myositis, which the pathophysiology is not understood at all. It's not unclear whether that's even a genetic versus an inflammatory disease, and there's no good animal model. So that's disappointing, but there are several other companies, and I hope that there will be another myostatin inhibitor trial in FSH. Yesterday, you heard about more specific approaches directed at FSH pathophysiology, and these might be within the 3 to 5 year time frame. So the Wellstone group has been working with Genzyme, and we're very excited about some of their approaches to knock down DUX4, and I believe so the Seattle group is working with GSK, but Stephen Tapscott could talk more about that in targeting some of the other misregulated proteins for FSHD. So I think that that's something to really be enthusiastic about. And then in a much longer time frame, I think that stem cell therapy is something that is continuing to develop and really will be an answer to many different muscular dystrophies. So let me move on to a little bit better news, and that is the progress in animal and cell models. And you've heard a bit about that yesterday, and I'm just going to talk a bit about work out of my lab and my institution, since that's what I know best. But I would say that there are many interesting animal and cell models. Some of the limitations to animal models are the degree to which the phenotype, the appearance, and the characteristics of the animal mirrors the human disease. And it's very unclear whether rodents translate well to humans. So the only pharmacologic agent that's been proven to have a benefit in muscular dystrophy, prednisone or corticosteroids in general, were developed initially from anecdotal observations in patients, not actually in animal studies. And in fact, corticosteroids don't work and may even have dilatory effects in animal models of muscular dystrophy. Conversely, several agents with promise in mice had no clear benefit in some muscular dystrophy trials, such as creatine, glutamine, and coenzyme Q10. And this isn't unique to the muscular dystrophy field. There have been beneficial effects in preclinical models of an animal model SOD1, an animal model of ALS, that really didn't translate to a large number of trials in ALS. In other fields, people have tried to get around the species difference looking at xenografts. And so an example would be when you make a human tumor model to assess if an patient's tumor will respond to a specific therapeutic regimen. And there have been some just major successes in that. So for instance, with multiple myeloma being responsive to Velcade. There are always limitations to xenografts, so it will always be a hybrid of species, and it's difficult sometimes to have meaningful outcome measures because you're not looking at a whole animal. And they're labor intensive. You don't get to just breed your xenograft. You actually have to make each individual one of them. So we started doing this with FSHD, and this is the work of a graduate student in my lab, Tracy Jung. And so many of you have participated in a muscle biopsy program with the Wellstone, in which the tissue of your muscle goes to multiple different investigators. And some of it goes to my lab and cut into several small strips of muscle. And this is a picture of the animals, a mouse's hind limb. This is the front of his hind limb, and we take out one of the mouse's muscles, the tibialis anterior, and then we sew in a piece of human tissue. And I have to say this was through a lot of trial and error. It was suggested to us that we could float the tissue. That's how other xenografts are frequently done, just floated subcutaneously. Well, that doesn't work for muscle, and maybe we should have known that. It really needs to have this stretch in order to form proper alignment of the myofibers. So, oops, sorry. So we sew it into tendons of another muscle that's remaining, and we close the skin. That was also a little bit of trial and error, which probably seems silly in retrospect, but you need multiple ways to close a mouse well, so we do it with glue and with staples so that the mouse really can't get at that. And then the last figure there is showing you this human muscle after many weeks. This is 20 weeks, and the muscle survives. Actually, what happens is those cut muscle fibers from the human degenerate, but the satellite cells that you learned about yesterday, those progenitor cells that came along for the ride, repopulate the space. And so you get a nice muscle there. And this is what it looks like underneath the microscope, and this was published in Human Molecular Genetics this year. So this is an H&E stain, hematoxylin eosin stain of the muscle, and this is the human portion, and this is the mouse portion. And the way we know that that's human is we can use a specific antibody that only recognizes human proteins here and doesn't recognize mouse there. And this is after 20 weeks. And in fact, we find that the graft survives for the life of the animal. We've looked at it much later than this now. One interesting thing, particularly if you want to go ahead and use it for gene therapy studies, is that the vasculature is a combination of human and mouse. So human here is in green and mouse is in red. And you can see that they're together, and in fact they appear to anastomose. So if you look down here in the corner, and I'll blow that up for you, that you can see the mouse vessels just sort of running nicely into the human vessels. And we know that these human vessels are functional. The human vessels here shown in red, and then red blood cells, the human vessel is in green and the red blood cells are in red, and so you can see the human blood vessels have blood in them. And of course, they need to be innervated. We need to have a nerve come to the muscle. Otherwise, it's not a model of muscular dystrophy. It would be a model of denervated muscle. And so here we show the nerve. We showed the nerve here in green, and then the postsynaptic membrane, which is on the muscle, and red, and they nicely co-localize. So that's a mouse nerve. Again, this is always going to be somewhat of a hybrid of species, but it's nicely innervated. And what's really important for FSH is that it's modeling some of the molecular characteristics. So we talked yesterday about DUX4 being a crucial marker of this disease, and a mouse does not have DUX4, and xenografts made from people who don't have FSH doesn't have DUX4, but xenografts made from people who have FSH have DUX4 in them. So we think that this is potentially a good model for us to use. It's certainly going to be a great model for us to study human muscle regeneration in general. You know, it's very difficult to pass through our institutional review board, you know, my injuring you and biopsying you multiple times to see how your muscle grows. So this is something that we can look at in this model. We can also use it to screen for molecular outcome measures. And we will be using it now to try to knock down DUX4 in various different ways. So I must be running out of time, so I'm going to go very quickly. Can I have 3 more minutes? Okay. I'm going to go very quickly through some work that I've been doing with a collaborator, Johns Hopkins, Gab-Sung Lee. And Gab-Sung Lee is a stem cell expert, and you've learned that you can take a patient's somatic cells and induce them into pluripotent stem cells so that they sort of go backwards in terms of their development. And then that iPS cell, pluripotent stem cell, can be made into multiple different things, a neuron or a cardiac cells, and those can be very helpful for drug screening and for transplantation studies, such as I've mentioned. And so we're doing this with FSH, so we're taking myoblasts from FSH volunteers, making iPS cells, and from that making myoblasts again. Now, why wouldn't we just use use myoblasts directly from FSH cells, well, FSH patients, and that's because those cells will only replicate a certain number of times. Versus one that has gone through an iPS cell is very much like an embryonic muscle cell that can replicate multiple different times. And why wouldn't we use a fibroblast, as many people are doing? Well, we think that maybe there is some epigenetic memory from the myoblast. Another really important aspect of what Gabsung is doing is that he's been able to make this jump here from iPS cells to iPS-induced let me go back. He's been able to make from the myoblasts to the iPS cells without the use of various oncogenes or other genes that most people use in order to make iPS. So this has more clinical relevance than most. And I'm just showing you here these myoblasts in culture, and on the left and on the right is electron microscopy showing the normal myofibrils. And we can inject these again into similar mouse models in which we can get expression of human laminin, which is a nuclear marker, and lamin and laminin, which is an extracellular marker. And these cells do also express DUX4, which is critical for our work with FSH. Potential applications of this is a model system for studying disease pathogenesis, drug screening, the cell-based xenograph, and someday what we're going to be able to do as a community, I hope, is be able to take those iPS-induced myoblasts, correct the gene, and then give that back to patients as stem cell, autologous stem cell therapy. So that's the ultimate goal. This is where I work, Kennedy Krieger. These are the people that I work with who have been involved in these projects, and collaborators at multiple different institutions, and in particular I'd like to thank my Wellstone collaborators. I'd like to thank funding agencies, particularly the FSH Society has been extremely helpful to us in terms of patient recruitment. Thank you very much.
Thank you. Thank you. Our next speaker, I'd like to preface our next speaker with just a few comments about the researchers in Holland. Locally in Massachusetts, we have a writer, Ralph Waldo Emerson, who wrote something like, as surely as the red needle points to north on a compass, meaning I can always rely on magnetic compass to tell me the right direction to go in. I think the Dutch have a very long legacy in FSHD. Runa Frans on our scientific advisory board, and George Padberg, very long-standing, dedicated researchers. And I've grown up, we've all grown up, we've gotten older in the last 30 years or so, and Silver has taken the lead for Runa Frans, and our next speaker, Basil van Engelen, has taken the lead for George Padberg, who recently retired. And Silver is in Leiden in the Netherlands, and Dr. van Engelen is in Nijmegen, the Netherlands. And so it's just an honor to present to you Dr. van Engelen. Thank you for coming, and thank you for being here.
Thank you.
Dr. van Engelen will talk on reducing chronic fatigue through exercise and cognitive behavioral therapy. Thank you.
Thank you, Dan and June, for the invitation to talk here about some good news, probably, Catherine, about an FSH trial we just performed and which is in press in neurology. It is on aerobic exercise and cognitive behavioral therapy, CBT, which reduce chronic fatigue and slow progression of muscle MR fatty infiltration in patients with FSHD. So in Holland, as Dan suggested, we have one national FSH center in Nijmegen and in Leiden, on the west and the east part of the country. And Sylvain told yesterday about the molecular aspects, and we see most of the patients in Nijmegen. And we know about 800 people in Nijmegen, but there should be 2,000 according to a study which is in press or electronically already available on the internet from our country. And average it's 1 in 8,000. It is not just another number. I think it is the best estimate in Caucasians at the moment because of the possibility we had of 3 independent groups of data. And so FSH is probably not, I don't know if it is the most frequent neuromuscular disease because myotonic dystrophy has not been studied with these novel statistical techniques, but FSH is at least among the most frequent neuromuscular diseases, but it is still a rare disease because it is less frequent than 1 in 5,000, which is the definition in Europe for a rare disease. Sylvain yesterday told about a long tradition of genetic research in Leiden. We have a comparable long tradition in clinical research in Nijmegen in the east part of Holland, with clinical diagnosing and research with quantitative muscle MR imaging, rehab, and functional assessment. I looked because of the question yesterday about pain, and pain in our cohort is in 75% of the patient. And the more dark the areas are, the more pain is present in FSH patients, so in the back and the shoulder muscles. In addition, we have also ectometers, which is a device that can objectively measure the amount of movement in 14 days. We collaborate with a lot of people in Europe and around, but our main collaborators are you, our patients with FSH. And in 2012, we published a paper on research priorities by the patients with neuromuscular disease, including FSH. And patients teach us that health status or disease burden is not only the disease muscle, but in addition to that, also fatigue, pain, sleep disturbances, and physical inactivity. And they ask us to address also these symptoms and to try to treat them. We did a longitudinal study and we made a model, not a zebrafish model, not an animal model, but a human model where functional health status is dependent on pain, physical inactivity, fatigue, sleep, and also the muscle weakness. And this is an FSH specific model. The model of myotonic dystrophy and CMT is different. Based on this model, we thought we should do a trial to decrease physical inactivity by aerobic exercise and to decrease physical inactivity by cognitive behavioral therapy in addition to addressing experience, fatigue, and sleep. This is the trial summary. It is published in BMC Neurology, and now the data are in press in neurology. It is based on a specific FSH model. It is a multi-assessor, assessor-blinded, randomized controlled trial. It is comparing usual care to aerobic exercise and CPT. Involved are 57 patients with chronic fatigue, and the outcomes are after 16 weeks and 28 weeks, questionnaires, ectometers, muscle MR. So after randomization in one of the 3 arms, the usual care group was randomized in aerobic exercise or CPT. Aerobic exercise was done by John Vissing, 16 weeks, 4 months of training, 30 minutes, 3 times a week. And what the patient did was assessed by heart rate monitors, and we did a submax test before and after, muscle MR, ectometers, 6-minute walk test, and also isometric contraction of the quadriceps. For the cognitive behavioral therapy group, we did the same muscle MR, ectometer, 6-minute walk test, and it was 16 weeks of CPT, including graded activity. Dependent on the complaints of the patients, we looked for the perpetuating factors for fatigue, like insufficient coping, dysfunctional cognitions, deregulation of sleep, low social support, and deregulation of activity in each of the patients. So I always like to think of fatigue in 3 Ps. there are predisposing factors, like the genetic mutation. 3/4 of the patients with FSH have fatigue. A precipitating factor might be an infection or overactivity, and the perpetuating factor is behavior or the coping strategy. And CPT is addressing these blue aspects, especially the perpetuating factors. The inclusion criteria are age 18 years or older and suffering from severe fatigue, which is measured by a CIS fatigue more than 35 on the questionnaire. Ability to walk independently and being able to exercise. The results. 42 sessions in mean for aerobic exercise, only 5 sessions of CPT, and 3/4 of the patients continue exercise or being active after the intervention period of 4 months. So the CIS fatigue, 35 is the cutoff between severely fatigued and not severely fatigued patients. And you see at T0 after 4 months and 28 weeks, the usual care group stayed severely fatigued, which was also the inclusion criterion. So during the 4 months or 16 weeks of intervention, the fatigue was the same also after 28 weeks. But the exercise group after 16 weeks dropped, which was significantly, and the same was with CPT, both are significantly. And remarkable is that the fatigue stayed the same also after the intervention period of 16 weeks. The reduction of the amount of patients with the CIS fatigue of more than 35 dropped in the exercise group from 28 to 14 and from 25 to 6 in the CPT group. That means that the number needed to treat is 2, and the number needed to treat for CPT is also 2. So you need to treat 2 patients with chronic fatigue and FSH to treat 1 with reducement of fatigue. The sickness impact profile, the social behavior and the usual care group increased, which means that there were more social disabilities. But in the exercise group, it dropped not significantly, whereas it did in the CPT group. In addition, we did also a quantitative MR. We looked at inflammation, but also at fatty infiltration in the upper leg muscle, because that is the muscle that is tested on a bicycle. And in the usual care group, the amount of fatty infiltration, the fat fraction, is around 6 to 7% per year. Whereas both intervention groups dropped, not that the fatty infiltration decreased to 0, but the increase was less compared to the usual care group. And in some muscles, just like the adductor muscle, it was a remarkable difference between 0 and after the intervention. So significant findings in both exercise and CPT are that the patients are less fatigued relative to the usual care group, and it lasted during follow-up. There was an objective increase in ectomotor activity and a slowdown on the MR in the muscle fatty infiltration. And in addition, in the CPT group, there was an improvement in social participation and improvement in quality of sleep. So there was a quite distinct effect on the disease burden. This is the disease burden before, and this is after the treatment. So there is really a gain, and I think this is quite a positive effect on this non-drug intervention. So we are not training, especially not doing strength training in the diseased muscle, because in the past we showed that moderate intensity strength training in FSH is not harmful, but there was insufficient evidence to establish its benefit. So we are not training diseased muscles, we are training persons with FSH, and that enables us also to improve quality of life, because we are not fixing on the muscles. Patients learned us that FSH is more than a weak muscle. And the side effects are in CPT not reported, and in the exercise there was some pain that spontaneously resolved after the intervention period, especially in the knee, saddle soreness, back pain, and neck and shoulder pain. So to make these numbers a little bit more, let's say, everyday life, one of our patients told us that he had complaints like daily fatigue on awakening, unquiet sleep, frequent awakening during the night, problems with biking, gardening, climbing stairs, walking, and he had also few social contacts. He had 9 sessions during a few months of CBT especially, and the modules within these patients were dysfunctional cognition regarding fatigue, insufficient coping with the disease, deregulation of sleep, deregulation of activity, low social support, and negative social interactions. And the results, according to the patient and his partner, was that his quality of life improved, more active, especially on the bike. He was not suffering from fatigue anymore, and he was skeptical in the beginning because he did not expect any result. And recently he interviewed for a job. So his FSH did not vanish, but at least his quality of life and that of his partner improved, and he is now more active in life. Catherine already told you about the pilots and the RCTs. Yesterday evening I did also a study in PubMed. There are 4 pilot studies, 2 that suggest a beneficial effect of exercise or training like electrical stimulation done by Sacconi, and there are 3 RCTs that are negative, using albuterol, and strength training, and salbutamol. So this is the first RCT using exercise treatment and CBT coming out in neurology with a beneficial effect in a substantial amount of patients. To conclude, this is an RCT showing that chronic fatigue can be improved in patients with FSH, the first muscle disease that have been shown to react to this type of intervention. Both aerobic exercise and CBT do the job, but exercise is more time intense, and only 5 sessions of CBT do even a better job. And what I like is that the patient told us that they want us to tailor these intervention programs to the specific needs of each of the patients. And it meets also one of the primary research priorities for NMD patients, as we have published in 2012. So while working on discovery of a causative treatment, symptomatic treatment can already now improve quality of life in patients with FSH, at least when cis fatigue is more than 35. But collaboration between basic and clinical scientists in this type of symptomatic trials may lead to druggable targets. Which biomarker or pathways in muscle are involved in improvement? So the red circle, can CBT cause epigenetic changes in muscle? Peter Jones yesterday talked about epigenetic modifiers, just like sleep and stress, and especially exactly these aspects that we use in our model to determine quality of life in FSH patients. So I think to bridge the gap between basic science and the patient, these type of symptomatic management can help to find druggable targets. In addition, Jet Stefland already told that the quantitative muscle MR might be a sensitive biomarker for FSH. Thank you for your attention.
Thank you. Thank you, Dr. Van Engelen. Thank you. We will now go to our question and answer session. So a little bit like Alice in Wonderland, I've gotten the meeting behind schedule. So right now we are about 20 minutes behind schedule. So what I'd like to do is cut the break a little short. We have a half-an-hour break, then we'll go for break for 10 minutes. So let's try to go for 25 minutes to 30 minutes now with Q&A, and then we'll take a short break and start again at 11. Another question here to the left.
A quick question for Dan. Could you just briefly describe the cognitive behavioral therapy that was involved in the test?
I think that's for you.
Not mentioning the name Dan, but I think you alluded to who is asking this question. Oh. And the CPT is tailored towards the specific problems of the patient. So in the interview with the psychologist, in each patient, the perpetuating factors for fatigue are identified, like inadequate cognitions or less activity or sleep disturbances. And dependent on the picture of the patient, then several of these items are addressed during the CPT. So it is more like personalized medicine, there are 9 items that can be addressed, and 4 or 5 are chosen for each patient depending on the questions and the problems in this specific patient. But rated activity is a part of CPT in every patient. So it is not only talking, but it's also being more active. And what we learned is that it is not necessary to sweat on the bike, just as I do a few times a week, but it is also equally effective to be active in daily life, taking stairs instead of the elevator, and so being moderately active all the day instead of sweating a few times a week. Also in Parkinson's disease, I can speak forever. In Parkinson's disease, we have the same. It is not important what you are doing, it is important the time that you are sitting and doing nothing. So to decrease the sitting time in Parkinson's disease is probably more important is to increase the amount of exercise.
There's a question here to the right.
Hi, another question for you. You said that there were no effects in muscle strength. Was that indeed tested and were no effects observed, or it wasn't part of the measurement?
Yes, we did a quantitative measurement in the quadriceps muscle, and there was no significant difference.
Another question to the left.
Yeah, I have a couple from the internet again. The first is from Scott, and he just would like to know what is considered quote unquote moderately intensive training. Is it just aerobic, or can it include weight training?
Moderate intensity is, so we have 2 types of training, strength training and aerobic exercise training, which is training your capacity or aerobic capacity. Moderate intense is between 65 and 70, between 50 and 75%. So above that is quite intense. So moderate intense is between 50, 55 and 70% of your maximal capacity.
Okay, thanks. The second one is from Lori. It actually came in late yesterday, if I recall correctly. And she was wondering if early, like before you start showing symptoms, if you're doing muscle development, does that help delay or offset symptoms later on?
We don't know. That is what we have to study, to see if this remarkable effect on the fatty infiltration in MR is also accompanied by molecular differences in the muscle. We don't know. We have to collaborate, as one of the slides I ended with. So between basic scientists looking into the molecular biology of the muscle and the fatty infiltration and the histology of the muscle in patients that have trained.
We have a question in the middle.
This is for both the first one's for Sabrina. So in your slide, you said something about the weight being below 17 or BMI or greater than 25. Is that also the case with able-bodied people, or is that specific just to FSH, that's when you're at risk, a higher risk for respiratory?
I think it's not specific for FSHD people, because also if you have a higher weight, you are keen to develop sleep apnea. And we are doing the correlation, the statistical correlation, but unfortunately I have not enough patients to be sure because of probability. But there is a trend that demonstrates that patients with overweight or severe overweight are the ones that develop respiratory involvement like sleep apnea. While there was a strong correlation between axial involvement and abdominal weakness and respiratory restrictive lung disease.
And then the second part would be for Basil, in that in your exercise study, I'm lucky in that I just recently in the last month found a gym in my local area that's fitness related specifically for people who have mobility issues. And are you expanding it beyond those? It looked like you only did people who walk or walk with braces. And we've found a way to where if I stretch out my wheelchair totally flat, we can do sort of like leg walking sort of movements. Are you looking more towards those full-time wheelchair users as well?
Yes, very good question. So now we are expanding in a project which is called Energetic, because we found out that the bicycle is not the best apparatus for an FSH patient, and rowing is probably better. You are saying no. There are also some the hand bikes, so we are trying to find which is the best, because with a bike it is frankly not possible to have enough, let's say, capacity, because it is only one muscle. So to improve your aerobic capacity, you should use more muscles. So we are now looking for other devices to have a more intense training effect.
We have a question to the left.
This is for Sabrina. You were talking about the coat syndrome and how with 1 to 3 repeats it was more severe. But your average age of onset was over 20. I guess what I found interesting is that more women had it than men.
No, I think...
Did I hear that wrong?
No, in a patient that has coat syndrome, they all have infantile onset, less than 10 years old, and they were severely affected, wheelchair-bound, typically very severely affected patient. The only patient that was different was a woman that has a mosaic, and this woman has later onset and two repeat. But in a mosaic, it was a somatic mosaic, so it was a little bit peculiar. Probably the percentage of mosaic in retinal vessel was high, and so she developed the same complication. But otherwise, all the other people were infantile onset.
Okay. I guess that answers. I just kind of wanted to clarify on that.
Mm-hmm.
We have a question to the left.
Follow-up question for Dr. Van Engelen. Did you say that rowing, you found rowing would be a more effective form of exercise than bicycle?
It might be in some patients with FSH, because the quadriceps muscle can be involved in such a way that let's say that the capacity is not used as it. So patients can probably then not achieve 60 to 70% of their aerobic capacity because of the weakness of the quadriceps muscle in some patients with FSH. So with rowing, you are using more muscles. So it might be that that is a better one. That's at least what we heard from some patients with FSH. But we are now investigating that, so I have no clear data, just some clinical experience.
Me? A question to the right. Robin?
Thanks. Just a brief comment on that question. I think any comments about the sex distribution would have to be regarded as very tentative. I just, after your comment, sort of made some mental reflections on the cases I've seen over the years, and there isn't a very obvious sex skewing. I guess also, as you say, they're concentrated in the infantile cases, but I can certainly think of numbers of adult cases in which the number of repeats is not of the order that you described. But I take your point that it is concentrated in the infantile cases.
Yeah, but we only detect in the database a patient that has complication associated with coat syndrome. So I think that this is not enough. We didn't study all the patients with the correct examination. For this reason, we only found maybe the most severe cases are infantile.
I mean, I was thinking of the cases with the overt disease requiring treatment. Okay, thank you.
We have a question to the left.
Me? Oh. I'm wondering about the exercise also, why you didn't consider swimming, because I've been swimming every day for many years, and I believe that that's what's kept me strong for all these years, and I'm wondering why you didn't consider that.
I think swimming is an excellent way of training, but the advantage of the bike is that you can quantitate exactly what patients are doing, and it has been used in a pilot study by John Vissing in the past, so it is easy to test exercise. But you're right, when you are trying to make it more, let's say, everyday approachable, then swimming is probably better, but it is not easy to do a trial using swimming as the intervention.
Thank you.
We have a question out here to the right.
Yeah, with regard to the CBT, I think you said that to address that, you would go in to a professional that would deal with the symptoms, i.e. fatigue. Is there something special about FSH that you would communicate to the psychologist or whoever the administrator of the CBT would be?
You know, we made this model based on a longitudinal study using questionnaires. And this model is FSH specific because pain is in this one, whereas in myotonic dystrophy, pain is not a problem. At least not coming out in the model. So this model is already FSH specific. And then each patient has, let's say, different modules that are important in perpetuating the fatigue in this specific patient. And so sleep and also social interactions are things that came out frequently in this group of patients. But as you know, in the past, in the Lancet, I think 50 years ago, a trial was published by our collaborators using CPT in chronic fatigue syndrome, using a totally different model compared to FSH patients. But there the effect was comparable, using different modules. So your question, pain, sleep, and inactivity are things that are, I think, quite specific in FSH, but not specific when you compare it to other muscle disorders, but specific probably when you compare it to chronic fatigue syndrome.
All right, I have my own personal question this time. This one's for Catherine. I'm really interested in, of course, your xenograft work and your iPS cell work. It's Don, way back here in the corner. What comes next for that, and do you have kind of the resources you need to take the next steps with that work?
It was your question was what comes next and resources. Yeah. So we have two studies planned. One is a collaboration with the Wellstone that is funded, and that is to look at knocking down DUX4 with AAV in the xenograft. And another is to look at knocking down DUX4 with a drug from Genzyme. So we're very excited to move forward on that.
We have a question here to the right again.
With respect to your approximately moderate exercise, let's just say you're using a rowing machine and you want to exercise more than moderately, you want to get your heart rate up even further. Do you see any damage, or does this exacerbate FSHD if you over-exercise?
Yes, this is a difficult question. We looked at pain, and the pain that was involved in our trial mostly was saddle pain, and so more local pain, but not only in the muscles that are used, so just like back pain. We did not look for CKs because that is unreliable as a kind of a, let's say, damage control in the muscle. So I would advise to do it with a physiotherapist that is experienced in training people with muscle diseases.
I have a question for the panel myself, actually. With the hearing loss, it seems like it's a very unique population. You know, 1 to 3 repeats and a certain, so it sort of yells out, this is, you know, hey, I'm very unique, you know, there's something very, you know, there's something good to be discovered. How can we get a better handle on biochemically what's causing the hearing loss and how that relates to the disease? And why is this so difficult?
I think it's very difficult to answer to this question because for the moment we only try to identify patient and then to try to establish group of patient and it was one of the aim of the registry, and then we want to study them further and maybe we will find out this type of problem. And also studying some atypical cases may help us in identifying these things. One important thing is the fact that, in my opinion, all the FSHD patients were considered as together. So you put together patient that has hearing loss starting in childhood and is part of the disease, with people that develop hearing loss later in their life, and this type of hearing loss may be due to other type of problem like aging. So if we put together all these patients and we make a study, the study will not be, doesn't have any good conclusion. If we isolated patients with very early hearing loss and we study them, I think we may find some doubt why these patients have this hearing loss. And there is also, and for retinal involvement is the same, is the fact that you study patient with clear retinal involvement due to the disease, and not later, because you may have retinal involvement also in other comorbidity and condition. So, and it's very important if we want to do some basic research to identify all these different factors.
Okay. We have a question to the right, out in the center.
For Drs. Wagner and Statland, since there are only 9 FSD studies going on, as you pointed out, are there non-FSHD studies that can provide benefit to the community based on their outcomes and what's going on for techniques or what they're looking at?
I think that's a possibility. So to rephrase your question, if I could clinical trials in other muscular dystrophies help FSH? And so let's say a drug is developed for Duchenne muscular dystrophy, becomes FDA approved, then it certainly could be used off-label for FSH. The difficulty might be, if it was a very expensive drug, getting your insurance company to pay for it because it would have an indication for a different disease. But there's also much less of a hurdle in terms of running trials. If a drug is already FDA approved, then certainly there would, for a different muscular dystrophy, then there'd be a lot of impetus to do a second clinical trial in another muscular dystrophy such as FSH.
Yeah, I mean, I think I agree with that. I think there's a couple different types of drugs when you think about doing trials. It's going to be a lot easier to repurpose a drug that's already been approved by the FDA because it's gone through the extensive safety testing if we can show that there's a rational reason to try it in FSHD. And then studies in other muscle diseases where the agent that they're using isn't maybe disease specific but really designed to either improve muscle mass or muscle strength or function. You know, if they're successful in another disease, that would be very encouraging, I think, for FSHD as well.
There's now, before the end of the year in Europe at least, they will start a trial done by ATIRE using an anti-synthetase which suppresses inflammation in muscle. And Don Kissel and Rabitabile in the United States are also involved. And in Europe, you and our group is also involved. And I think we can start before the end of the year.
That's excellent.
but that is more a general approach, not a FSH-specific one.
2 or 3 more questions. I'll go to the left, out in the center. Sorry, I'll go over here to the right. Alexandra, I'm sorry.
I just had a question for the people who are setting those registers of patients with FSHD. That maybe one interesting question to ask would be whether they have had cancer. Because we saw yesterday that there's an increase in the activity of the Wnt pathway, which is something that is also observed in cancer. There's an increase in oxidative stress, and this is known to be associated with increased risk of cancer, increase in inflammation, also a risk of cancer. And it could be an interesting study. We were discussing that with somebody from the FSH Society yesterday, that if there might be any link found with cancer, that might open much larger avenues for funding, because there's a lot of money in cancer research. Thank you.
There is a study that is going on in Nice and is almost finished, comparing FSHD1 patient with FSHD2 and FSHD1 plus 2. And in this study, we study also comorbidities, like for example cancer, but also autoimmune disease, metabolic diseases, and so on. So we are doing the statistical analysis. And I think maybe next year, beginning of next year, we will have all the data available. I cannot make any any guess on the result because it's very complicated. Because in a general population, the frequency of a certain cancer is very high, and so it's very difficult to draw conclusion.
Question to the left, center.
Thank you. It's another exercise question. Obviously, there have been some limitations in working out. So I started actually using the sauna for just to feel what it's like to sweat. And you know, if you have range of motion issues, it's just something that I've added as a health and wellness component. Obviously, it's very hot, and you actually are sweating quite a bit. Would you see that there are any adverse effects that could have, or would you say that maybe that's also a helpful routine to get into? With the sauna after a workout or something of that nature?
I think based on our trial, I cannot say anything reasonable about this question. I think we can talk in private on your specific case, but from our data, I cannot give, let's say, an answer which is based on the data of the trial.
Okay, one more question, then we'll go to break.
Okay, this is for anybody. What's your thoughts on a combination of a high-protein diet and then intense workout with either a human growth hormone and or steroids?
Who's one?
You said anyone.
Anyone.
Yeah. I don't know that I can give you a specific answer to that question. I mean, I think each of those components you would have to look at separately: growth hormone or intense exercise, or sorry, what was the third?
High protein diet.
Oh, high protein diet. Yeah. So I'm not sure. Does someone else want to?
In my opinion, it's very difficult to measure the effect of one thing. If we put together too many things, then the result would be very difficult to interpret, because we may say that it's not effective because the effect of one of the different like let's say growth hormone reduce the effect of high protein diet. So I think we have to start with one by one approach before putting together in cocktail or I don't know, in associating different type of therapy. And there was no rationale to put them together.
Thank you. around one of applause. Thank you very much. I'd like to think since we got behind schedule, let's try to take a short break, 10 minutes, and we'll be back here at 11 o'clock. So thank you. Okay. Good morning. Good morning. Could we have people come in from outside? As we should start the second session of our morning talks. So from 11 to 11:45, we will have 3 talks on different dimensions of FSHD. We will hear about facial surgery, physical therapy, and then also clinical trials, preparedness and readiness. I'd like to invite our morning speakers up, Dr. Sri Panja, Dr. Mohani, and Dr. Hummel. If you could find your way to the front. So our first speaker is Sri Panja from the University of Rochester Medical Center. I've known Sri for 20 or 25 years. Sri Panja is one of the world's foremost experts in physical therapy on FSHD and has been very involved and engaged with planning and running clinical trials. Physical therapy is a very important dimension of FSHD in our care, and it's an honor and pleasure to introduce Sri Panja, who will talk on update on physical therapy and exercise recommendation. Thank you, Sri.
Thank you, Dan. I've had the pleasure of knowing Dan and his mom, Carol, for a long time and working with the society for a long, long time. I did not have a slide like the others did about my colleagues and the source of funding. So I'm just going to go back and say that I want to take this opportunity to acknowledge everyone that I've worked with over the last 30 years. I've been at the University of Rochester since 1980, and I've had the privilege to work with some of the major forces in neuromuscular disorders, Dr. Griggs, Dr. Moxley, Dr. Tavell, and also across the world. The folks at Leiden, we've had a partnership with Silver and Dr. Padberg and others for many, many years. And really, when I stand before you, what I bring to you is what I have learned over those 30 years. And definitely not the least, but for me, the most important group of people that have contributed to my knowledge and growth personally so that I can help you are the patients and families that I have worked with. Because each time I speak to one of you, each time I get an email from one of you, each time I see one of you in clinic, each time I evaluate one of you for research, I learn something new each day. And that would be hard to put on a slide, all the faces and people that have contributed to my learning. So I just want to acknowledge that now. So in 2007, the FSH Society gave us a grant to develop this little guide, and I don't know how many of you have had the opportunity to use it. I hope you have, because we were finding that people would say to us, you know, it's so hard to find doctors or physical therapists who know about FSH, and you know, they treat us like we have an orthopedic problem, a rotator cuff injury, and I'm not sure that what they're telling us is the right thing to do. And that's when the FSH Society funded us, Wendy King at Ohio State and I, to develop this little guide mainly to assist physical therapists and patients develop an individualized plan of care. We felt that it was essential that yes, there would be a broad outline and guidance, but really, as you can see here, Each one of you is an individual. Each of you is at a different stage in life, different stage in your disorder, have different issues, personal factors, family factors, work factors. And so to say that, you know, this is the program for every person with FSH would be silly. We have to take a holistic approach and look at what is the right mix of things for every individual and help develop a plan. So that was basically the goal of the guide, and I'm going to move this a little so I can look at the slides right here. So we really wanted to develop something that was based on best research evidence, clinician expertise, and patient references. And much of the information in that guide is still very, very pertinent. But, you know, that was 2007, and as you've heard over the last day, so much has happened since then. And what the decision was made last year that we need to update the guide, and I'm working on that right now. Actually, the booklet part is done, and what we want to do is now include the current knowledge of genetics, so include FSHD type 2 that we didn't talk about in the guide, talk about a better understanding of the DUX4, and I realize that it's a moving target, and you know, each day a new discovery happens and a new paper comes out, and we need to sort of reference it. Much has happened in the world of exercise and physical activity recommendations. I mean, we heard new information from Dr. Van Engelen this morning. So we are trying to incorporate and update all this information in the guide. And the second thing we've decided is to add short video clips so that when we talk about range of motion exercises, what exactly are we talking about? What does it mean? So that it becomes a little more helpful for patients and families and therapists who are going to use this guide. So stay tuned for it. The plan is to have it all out before the end of the year, and hopefully you will find it interesting and helpful, and we would love to get feedback on what more we can add to it. So for today, really, the goals of the presentation for today is to discuss the pertinent information from the guide and then provide some additional information that we are going to use in the updated guide. And these recommendations are mainly based on consensus and some research evidence. As Dr. Van Engelen pointed out, you know, the gold standard is the randomized controlled trials. But there are very few randomized controlled trials in terms of physical activity or exercise or diet and all those things. So really a lot of the recommendations either come from what is being recommended for the general population, next what is being recommended for the general muscular dystrophy population, and then within the FSH population. So what are the goals of physical therapy? As a physical therapist, when I meet a patient, and it doesn't matter to me if it's a patient with FSH or a muscular dystrophy or stroke, irrespective of the condition, our goals are to maintain optimum health and wellness. We take a holistic approach to this. We know that there can be secondary complications because of your primary disorder. So we want to try and delay or prevent these secondary complications as much as possible. We want to make sure that we are able to help guide you to maximize your functional abilities. Yes, you have a muscle disorder. Yes, you have weakness. Yes, it puts limitations on what you can do. But together, can we come up with solutions to maximize your functional abilities? And those solutions might be an assistive device, change of your physical environment, a little change in your routine. There are lots of things we can do to improve or maximize your functional abilities. And I think this then helps improve and maintain the quality of life. And to me, that's the most important thing. Your quality of life and your role function, whether it is that of a parent, grandparent, uncle, aunt, are you able to do the things that you really want to do that are important to you? Are you able to, go out with your friends, whatever it is that's important in your life. We want to try and do that. Now, as I said before, I truly believe that this requires an individualized plan based on your individual factors, and this plan may include guidance about appropriate activities and exercise. If pain and fatigue are a huge issue, then we need to address that. And it may also include, as I said, orthotics, mobility, and assistive devices to make life easier. Now, we all know that over the past several decades, the benefits of physical activity in the general population have been well documented. We know that it helps us control and lose weight. It reduces the risk of cardiovascular disease, reduces risk of diabetes, reduces risk of some types of cancer, helps strengthen bone and muscles. It has an impact on our mental health and mood. And it increases our ability to do daily activities, and some studies have also shown that it increases chance of living longer. So based on this evidence, in 2008, the CDC put out an activity guideline for Americans. And if you just Google physical activity guidelines, it'll bring you to this website. And what it does is basically makes recommendations for the general population. And it talks about high intensity, moderate intensity levels. And what I have chosen to do here today is only to talk about moderate intensity. Because one of the things we do know, based on all the studies that have been done in muscular dystrophy, is really people are still very wary of high intensity aerobic or strengthening activities. If you're going to do anything, it has to be in the moderate or lower level, again, depending on where you are in your disease stage. So what are the current physical activity guidelines? It says 2 hours and 30 minutes of moderate intensity aerobic exercise every week. So that means 150 minutes. You can spread your activity out during the week. So you may choose to do 30 minutes 5 times a day, 5 days a week, not 5 times a day. And recently, they have even said that you could even break it up into chunks of 10 minutes at a time. It does not have to be 30 minutes. And I think more and more the data shows the problems with inactivity and sitting. So just even getting up and walking and going to the water cooler or going to the mailroom, or instead of sending an email to the person in the next cubicle, walking over and talking to them is good for your health, okay? So, and again, as I think Dr. England said, instead of taking the elevator, if you are able to walk up and down the stairs, take the flight up of stairs, one flight of stairs, instead of standing, button pressed, waiting for the elevator. Weave in physical activity into your daily routine as much as you can, rather than, thinking that exercise and activity are only good for you if you put on your gym clothes and go to a gym and work out there. Yes, there are definitely benefits to that, but there are also benefits to just weaving it into your daily routines. Now, moderate intensity activities and exercise, what are they? When we get technical, we might talk about it in terms of heart rate, VO2 max, and again, as Dr. England said earlier this morning, 50 to 70% is the range that we go for. Well, there's a very simple definition. Yes, you can now get monitors that you can slap on your wrist, and things have become a lot easier if that's how we want to go about it and be a little formal. But the simplest definition of moderate intensity activities are those where you can still carry on a conversation while you're doing that activity, so that you're not huffing and puffing so much and you're not so out of breath that you can't talk to the person that you're exercising with or walking with or dancing with or whatever it is that you're doing. And again, you know, I would recommend that weave things into your daily activities, especially if you live in the Northeast. Mowing, raking, snow, all those things that you have to deal with are all activities, if you can participate in, are wonderful things to do. What about strengthening activities? The guidelines, the general guidelines recommend 2 or more days a week of muscle strengthening activities that work all major muscle groups. This includes the muscles of the proximal muscles, the thighs, hips, abdomen, back, shoulders, and arms. And this can be done using body weight, free weights, elastic band, hydrotherapy, whatever equipment for resistance, etc. So what is moderate intensity of strengthening activity? And again, in the technical parlance, we talk something about 1 resistance maximum. That is the weight or resistance that you can only lift 1 time. So you know it's the maximum. You cannot lift that again a second time. Then we talk about something called 10 resistance maximum. So that's something that you can only lift or push against 10 times. And what we usually tend to do is take about 50 to 60% of that and work with that in terms of resistance exercise. But I would suggest to you that you really start slow and slowly increase. And listen to your body and listen to the signals that it's sending you in terms of, are you overdoing it? Is it tiring you out? Are you able to sleep well after all that activity? Do you get up rested the next morning? Yes, when you start something new, you're bound to have a little amount of soreness, but it should not persist. It should not make you hurt too much. It should not fatigue you for too long. So then in 2011, the American College of Sports Medicine put out a position stand on quantity and quality of exercise for developing and maintaining cardiorespiratory, musculoskeletal, and neuromotor fitness in apparently healthy adults. I love that apparently. Because I mean, as you all know, we are all apparently currently healthy. They also said that these recommendations, though they were for apparently healthy adults, they can also be used to develop individualized plans for adults with chronic diseases and disabilities. And the one thing they added to the 2008 guidelines that were published was that in addition to aerobic strengthening and flexibility exercise, they also recommended neuromotor exercise for balance, agility, and coordination. And I think this is important because as the general population ages, we know that falls are a huge issue, that there are so many hip fractures, and it's not only a personal burden, it's a huge societal burden in terms of cost of care. And that's true with the population with disabilities and chronic diseases. I hear this all the time for patients with muscular dystrophy that I've followed for the last 10, 20 years, that, you know, they're getting weaker, their balance is getting worse, they're taking falls, and they're afraid of falls, and that they're cutting back their activities, and that causes more disuse atrophy and a greater impact on their psyche because they're not going out as much, not able to do things with friends. So I think it's important that assessment of balance and management of falls become an important part of the program. So what are the current recommendations for individuals with FSHD? There was a workshop in 2010. It was an international workshop, and they recommended that, you know, aerobic exercise, strengthening exercise, flexibility exercise, hydrotherapy or pool activities, and recreational activities are all important and need to be incorporated into whatever plan we decide for and recommend for patients. How many minutes do I have, Dan? 2 or 3 minutes. Okay. And so where did this, what was the evidence underlying these recommendations? In 2005, Dr. Wissing's group had done smaller studies of aerobic training and said that aerobic training is safe and can improve fitness. Cup and her colleagues did a review of all the evidence that was there for exercise and said there is level 2 evidence, meaning likely to be effective, for strengthening exercise in combination with aerobic exercise for patients with muscle disorders. And Cochrane review, which is a stricter review, which only includes randomized controlled trials, said moderate intensity strength training appears not to do harm, but there is insufficient evidence to conclude it offers benefit. As long as it does not do harm, that to me is important. And I think we have now started being more comfortable with saying, yes, do exercise, because at least we feel it will not do harm. And the benefit may depend again on what stage you're at, what you can do, etc., etc. So we've already talked a little about the aerobic exercise, the strengthening exercise. I think range of motion exercise or stretching exercises are important, and especially in people who spend a majority of their time in a wheelchair or have limited abilities. You know, our joints are like any other mechanical components of a car. They need to be oiled, they need to be moved, they need to be used. And if you have scapular weakness and you really can't do much with your shoulders, then it's quite likely that your functional activities that you're able to do or that you perform become less and less. So even though it's your shoulders that may be affected, to a certain extent, you are now doing less further down the line. So that causes disuse atrophy there. Also with the shoulders, if they are not getting the full range of motion, you know, that may be contributing some to the discomfort and the pain. So we want to make sure that we recommend and that people perform range of motion exercises, preferably on a daily basis, and that if you're able to do it actively, and there are gravity minimized positions that a physical therapist can demonstrate to you and that we hope to demonstrate in the video clips, where even if you can't lift your arms up in a standing or sitting position against gravity, you might be able to do it in a lying down position. And how do you do it? So that's one thing. Or you might do an active assisted exercise so that you can do some of it on your own, but part of it you need help. Or if you can't even do that, we can train a family member or demonstrate to a family member or with a family member how it might safely be done passively. So that's important. Then there are, of course, you know, some people, as I heard someone talk about swimming in the earlier session, find that swimming is very helpful to them. And, you know, water has been used since millennia for exercises. There's the buoyancy factor, which, you know, helps people with weakness. People who can't walk on land may be able to walk in the water. Water can be used to provide assistance as well as resistance, and the temperature can have an impact. You know, I enjoy going into a nice warm pool. Sauna, I would love it. So, but some of the disadvantages for some folks is the dressing and undressing. You know, maybe it's too much for what you gain from being in the pool, or accessibility issues. If you're not able to go down the steps and there's not a ramp into the pool, that might become an issue, or the distance or the cost. So even though we tend to recommend hydrotherapy and pool exercises for its benefits, we have to think about, you know, what are some of the disadvantages or barriers that may keep people from using it. And lastly, recreational activities. I think those are essential. To me, if something feels good, that's half of the psychological impact of exercise and activity. And to me, pick what you enjoy doing. Pick what you want to do with someone else. We know from the exercise and activity literature is that when people do things with someone else, they tend to do it more often than when left to themselves to do it. So pick things that you can do with someone else. Make it a social time as well as a physical activity time. And there are so many options. People ask me about yoga, people ask me about many, many different things. And the key is to work with someone who knows FSH, who's, if they don't know FSH, is willing to learn about FSH and work with you. Two things, and I'm going to wrap up. There's been a neuromuscular electrical stim has been studied for decades in individuals, not only with muscular dystrophy, but other chronic conditions that cause atrophy and weakness. And the goal of using neuromuscular electric stim is really to prevent disuse atrophy and provide a passive form of strengthening for the very weak muscles that we might not be able to strengthen with active exercise. And actually, it's Dr. Sacconi's group that published the study in 2010. They did an open pilot trial, 9 individuals with FSH. They stimulated these 3 muscles 5 days a week for 5 months. And they concluded that electrical stim appears to be safe, feasible, and well tolerated, but that it requires further study. We need to know, do you have to do it 5 times a week? If you continued past 6 months, is it still beneficial? And they also felt that multi-site studies with more participants need to be involved. I'm going to go past this. Pain is a huge issue. Low back pain, scapular pain, some of it due to the abdominal weakness. We have found that for some folks, some kind of an abdominal support is helpful. Fatigue, I'm not going to talk about. Dr. Engelin has shared their experience. But again, from the same group, falls in FSHD. What is the epidemiology and pathophysiology of falls in FSH? And we know weakness is an important risk factor. The elderly fall, people with chronic disorders and disabilities, there's a higher percentage of fall. But what is the relationship between weakness and falls in FSH had not been documented. And so the folks here did a study of prevalence, circumstance, and consequence of falls. They used a questionnaire and a prospective 3-month follow-up. It included 73 patients with FSH, 49 matched healthy controls. So everyone answered the questionnaire, and then they assessed strength and balance in a subgroup of 28 patients. And what they found was 30% of their patients reported falling at least once a month. Of these 30%, 70% reported injuries. The falls occurred at home. Folks usually fell in a forward direction, and the fallers were also unstable on stairs, on rising from a chair, and while standing with eyes closed, and that the frequent fallers had great weakness. And I bring this up because it's part of the recommendations for neuromotor training, balance, falls prevention, etc. And we know that this is something that needs to be addressed. So very briefly, coming back to the need for individualized recommendations, we need to take into account the age and hence the activities that might be of interest to the person. If it's a child or a teenager or a young adult or an elderly, their interests would be different and their clinical profile would be different and their personal profile would be different. And we need to take into account all these factors when we work with you to develop what is best for you. And in terms of implementation, you need a good evaluation, you need proper recommendations, you need good monitoring and adjustments as necessary. And to me, the biggest factor is the self-monitoring. This is a lifelong condition. I do not expect you, the healthcare environment cannot support the cost of everyone seeing a physical therapist 3 times a week. that is not necessary. There might be acute times, a fall, something surgical correction of the scapula. Those are incidents where you would need acute follow-up more frequently. But other than that, we are talking about working with a physical therapist as a guide, trainer, if you will, and monitoring every 3 months, 6 months, 12 months, as the need be, but you are going to be the person that manages your health, activity, and exercise needs, okay? But I think the important thing is teamwork and partnership, and I hope that's what we do.
Excellent talk, thank you. Thank you. Our next speaker is Dr. Kofi Bahani from Johns Hopkins Medical. Dr. Bahani will talk about facial surgical and non-surgical option for facial reanimation in FSHD. Thank you, Dr. Bahani.
Yeah. So it's a pleasure to be here, and I'm learning a lot just sitting and listening to all the previous presentations. I work solely on the face. I may go to other parts of the body, but everything I do always ends up on the face. So it's very interesting to see that a section of this dystrophy really affects the face. If you look at the face, there are a lot of muscles, and the muscle is really like the kidney of the face. It's the end organ. It's connected to the brain by a complex nerves that starts from the motor cortex, ends up in what we call the facial nucleus in the brainstem, sends out multiple nerves, but in the end, it all ends up in the muscle, and without the muscle, everything else before it doesn't work. It's useless. Most of the facial paralysis that I work with tends to affect the nerve. And usually we are struggling to find another nerve to get into the muscle. This is a totally different problem. But some of my experiences working with people who come to me with complete paralysis for 10, 20 years, or children who were born without muscles, sort of informs what we can do for FSDH. And those are some of the experiences that I want to share with you. This is a picture that I took from a London news magazine showing you the different gestures that the face can do, and we communicate with that a lot. And when you lose that ability, you can communicate with your face. Sometimes people think you're angry when you're not. So it's very important to look at the face and how this disease affects this. I want you to come away with two main things. Muscles on the face give tone, and muscles on the face give contraction. And the weaknesses that you're seeing in FSDH is affecting tone and contraction, and the symptoms usually is because of loss of tone, loss of contraction, and the treatment options that we have are directed to improve tone or improve contraction. So I'm going to focus on what we can do for tone and what we can do for contraction. So what is tone? So if you look at someone's face at rest, the reason why their face doesn't just fall off is because the muscles in their face have a basal tone. Some nerves are firing into it to give it its length, and it holds the face. It's the reason why the eyelids will hold their position. Is the reason why the corners of the mouth will hold their position. Is partly the reason why you can breathe at rest and air just kind of goes in and you don't see the nose collapse. And otherwise, by what we call Bernoulli's effect, every time you take a breath, your nose will just sink in. And in some people, I'm sure in this room, that happens to them. It's also the reason why your lip doesn't roll down. So that is tone. Tone is the muscle maintaining its length at rest. Contraction, on the other hand, is why a child just kind of, the child is doing something, you can whistle, you can blow, and it's the final result gives us all the wrinkles that we don't like. So muscle contraction is what kind of squeezing things all the time. So tone holds things together, contraction calls on that muscle to shorten its length and give us animation to the face. So these are the two things that I want to sort of focus on. In FSDH, both tone and contraction diminishes, and it affects people over a period of time at different rates. And in some people, they will tell me, when I talk, there are certain sounds that I have difficulty pronouncing. The P's and the B's, those are what we call the plosive sounds. And the reason is that you have to generate pressure in your mouth and in your cheek to let out that sound, and you can't do that. It's also some reason why some people wouldn't want to eat in front of others in a restaurant, because they can't keep the food in their mouth and move it around. I heard an earlier speaker talk about dysphagia. So dysphagia, we talk about various phases of dysphagia. The oral phase requires the tongue to move the bolus in the mouth and propulse it back. And usually you need to seal your lip, move the cheeks in, and that portion of oral phase dysphagia is affected. Probably not so much at the level of the pharynx. Once the food goes to the back of the throat, you do fine. But the first phase of swallowing, moving the food in your mouth and pushing it back, that's where you may have problems with. If you can't drink from a cup because it just seeps out. When you're brushing your teeth, it wants to come out. So those are most of the time mostly issue with tone and a little bit of issue with contraction. So what do we know with tone? There's a study that was done by Clark and Solomon looking at normal patients and putting a pressure device, which we call the IOPI, an Iowa pressure device. If you put it in the lips and you ask someone to push on it, it will generate some pressure. And in normal people, for males and females, females may be able to generate a pressure of 22 kilopascals. And males 38 kilopascals. I did this measurement in 3 FSHD patients. 2 of them could generate 0, and 1 person could generate 1 kilopascal. So you can't really generate that pressure around the lip to generate those plosive sounds or keep fluid in the mouth. So when I see this in patients who come to me with FSDH and that is their primary complaint, I can keep food in my mouth. When I would like to be able to drink and not have it seep out. I would like to be able to have a clarity in my speech and articulation. I may have them do this test to see how much pressure they are generating and then offer some solution to increase that pressure. And this is my outcome measure, one of the outcome measures to see that the intervention that we are giving works. And that's the first non-surgical option I want to offer. So people come to me for cosmetic reasons. They want me to bulk up their lip, and I will take this stuff and then just inject into their lip and then shape their lip and it gets fuller. But I also realized that you can use the same approach injected in a different way to increase tone in the lip with someone who has dystrophy affecting muscles of the lip or paralysis affecting the muscles on the lip. So in the 3 patients that I mentioned to you, go back. If you look at the graph on the left, you see all those dots. The very low one pre-injections were 3 FSH patients who they are pre-1 kilopascals, and when you inject, it increased their pressures they were able to generate increased 6 to 7 folds. So now they would tell me, you know, people can hear me clearer when I speak, and I can hold fluid or water in my mouth and maybe even drink out of a cup. So it's a very simple means of increasing tone around the lips. And the injection is targeted. What do I mean by that? So this is an example of a patient who had this injection done. When I asked her to talk, I can tell where the air is just escaping from the mouth, and I will just, under topical anesthesia, put a numbing cream and inject in that area to generate the pressure. Now, where the level at which I inject, I try to avoid the muscles. I don't want to do too much to the muscles, so I'm going to the tissues that are surrounding that area. And my goal is I want to statically use this injection agent to improve tone. Most commonly, we use a material called hyaluronic acid. Hyaluronic acid is a gel-like material that is cross-linked, and your body makes enzymes against it, so it's not a permanent substance. So, depending on the type of material I pick, it may last for 3 months, or 3 months, 6 months, or up to a year. So if I want to see if this is going to be a good solution, I may pick something that just lasts 3 months. And if we get the desired result, then the next time we inject it for longer. The alternative for using the hyaluronic acid is your own fat, and fat I always can't get. So I take a liposuction cannula and I can liposuction the fat, process it. If I want large volumes of injection beyond the lip, perhaps in the cheek, in the mid-face, then I'll go to fat. So because you can get as much as you want. And in doing these studies, you can see the pressure that is generated increasing. Okay, go there. So, like I was saying, areas that we can target with this injection includes the cheeks, the lips, the brow, and the eyelid. I'll talk to you more about certain things that we can do the eyelid. I think the speaker from France mentioned lower eyelid levator is something that we've been doing for a while. You can release the lower eyelid and ask lower eyelid retractors so that they don't pull the lower eyelid down, and it allows the lower eyelid to go up. But if anybody's been stung by a bee around the eye, when your eye swells, it closes. So if you have a problem with your eye closure, if I put a little bit hyaluronic acid in some areas, it's going to push the eyelid up and it will close better. So you don't have those conjunctival issues. So this is all the non-surgical means of trying to improve tone on the face to sort of overcome some of those functional deficits that this disease causes. So on the screen, you're seeing examples of those hyaluronic acid. It's the same ones we use for cosmetic purposes. So whenever I'm going to use it for a FSH patient, I would write the insurance company and saying, I have to come up with a fancy name. If I told them I'm just plumping up your lip, that's not going to work. So I say I'm doing an augmentation kiloplasty. Kiloplasty is what we do for cleft lip patients. You kind of rearrange the lip, and the indication for this is for dysphagia. And usually they tend to cover it. Okay, we'll go forward. Okay, so this is another patient who had it done to the lower eyelid. On the left, she could close her eyelid and you can see what 1 to 2 millimeters of scleral show. You can see 1 to 2 millimeters of the eye visible, and after the injection, when she closes her eye, it fills and closes fully. Again, this is it's reversible. If I don't like the effect, I can actually inject an enzyme that takes away the agent that I injected quickly. I've never had to do that. You can always kind of go on a conservative, put a little bit, see the effect, come back, add a little bit more. Okay. So that's one non-surgical means of improving tone. The second means for the lower eyelid, as you saw, with patients that have so much loss of tone in the muscle around the eye, the orbicularis, that the lower eyelid droops down and they can't blink to spread tears over the eye to keep it from drying, and they tear all the time because the lower eyelid can't hold the tears in. The goal is to get the lower eyelid to move up. In the lower eyelid, there are something called the capsulopalpebral ligament that tends to pull the lower eyelid down. So in this particular case, if you divide that ligament, the eyelid is not pulled down. But in addition, in very severe cases, I will put something called a collagen matrix, as shown in this picture, and it forces the eyelid to sit up. You'll be able to, it dissolves over time because your body sort of replaces it with your own tissue. These are simple means of trying to improve tone on the eyelid. So I'm going to move quickly to contraction. So with contraction, you can either improve it by strengthening the muscle that you have. So that's why we've heard earlier on about muscle strengthening exercises. If that is not enough, you can recruit additional muscle, bring muscles from some other part of the body to help the function that you're trying to improve on the face. So I'm going to talk about that. In the face, when you bring in more muscle, the goals are usually trying to improve tone again, and number two, to improve your smile, improve your eyelid closure, and also improve lip strength. Okay. There are three main methods of doing that. On the bottom, you can transpose a muscle. What I mean by that is you move a muscle that has one function, move it from its area into another area so it starts doing a different function. And I'll show you an example on that. Second example is you can move a tendon. You don't move the muscle, but you reposition the tendon of that muscle to a different side and ask it to do a different function. And thirdly, you can go to a distant portion of the body, find a muscle, bring it to the face, and let it do a new function to help the weakening function that is resulting as a result of the dystrophy. Okay, so these three pictures are sort of showing what I just explained. Top left picture showing muscle transposition. In this case, there's a muscle on the side of the temple called the temporalis muscle. Its main function is to help you kind of pull up your jaw. We can borrow a slight piece of that muscle in the middle. without significantly affecting the residual function of that muscle, and then tunnel that muscle around through the cheek to improve tone in the cheek, and to the lip to provide support to the lip, and also to improve movement. The second picture on top in the middle is showing us the same muscle just moving the tendon to a new desired position to improve tone around the lip and also to improve movement. And the last picture is showing a muscle move from the thigh brought to the face in someone who has really weak muscles in the face. Okay, so let's see examples of each. Okay, now the difficulty in FSDH is that not all muscles can be donor muscles. There are some muscle, you can't transplant a muscle that you know in 3-4 years is going to be involved with the dystrophy. You have to try to pick out muscles that are usually not involved. So this is an example of a patient who underwent the temporalis muscle, just a small strip from the middle, tunneled through the cheek to give tone and also to support the corner of the mouth. And as you can see, the downturned mouth, corner of the mouth is now elevated outside. And then there is a little bit more clarity in speech. And when she wants to smile, you can get the face to move. Okay, I'll try to run up pretty quickly. This is an example of how the temporalis tendon transfer is done. We go through the mouth and find the tendon on the jawbone, and in surgery we can actually measure how much tension we need to put on the muscle. We can see it move and then just sort of try to get the desired movement that we want. I'm going to skip through these quickly. And this is a patient who just could not smile because there's just no muscle on the face. And on the table, we can see the escutcheon, and that is going to happen after the surgery is done. This is another patient who, on the right side, was born with no facial muscles. So this will simulate what you see in a muscular dystrophy. And this is an example of doing the same surgery afterwards. And on the right side, you can see now she can move, and she has more symmetry when she tries to smile. And she can move it independently. And this is the temporalis muscle, which does not seem to be involved in FSDH, at least from the patients that I have evaluated. Okay. The last category is going somewhere distal from the face and getting a piece of muscle. In this case, this muscle that is being shown is the gracilis muscle. In general, in the pictures that I've seen, it should not be affected in FSDH, but this disease is so broad spectrum, has such a broad spectrum that you have to do it on an individual basis. There are some patients that may have weakness. You never want to transplant a already weak muscle. So if you have really no tone in the face and we really need to bring some muscle, this may be a candidate muscle. There are other muscles that we can also select. And usually we take a small piece of the muscle, put it in the face, connect a nerve in the nerve blood vessels, and then we can get the face to move. So this is a patient who had weakness on both sides of the face, and we took a small piece of muscle from the thigh. I'm going to skip through this video, and afterwards we can get the face to move on both sides. Okay. We are always looking for candidate muscles. The eyelid is a very tough area. In the neck, there's a muscle called the omohyoid muscle. It almost doesn't do so much. It's a muscle that we routinely cut when we do a neck dissection. And we are working on trying to transpose this tiny little muscle around the eyelid to the corner of the mouth in patients who really, really need some muscle brought to the face. And when you do such surgeries, you have to connect a nerve and blood vessels. The advantage in FSDH is that the nerves usually are okay. The muscle is the problem. Most of the time on the reverse, if you have facial paralysis because of a nerve problem, even when I have a muscle, I also have to go look for a nerve. But in this situation, the nerves are already there. So some other simpler procedures, when the lip is kind of drooping over, you can do lip tightening procedures as shown on the right top segment. If you take a small wedge of the skin and rearrange the muscle, you can make the lip tighter so it regains some more continence. And there are also some eyelid tightening procedures that can be done to improve the eyelid closure. So in summary, the goal of trying to design surgical approaches to rehabilitate the face in FSDH is to try to improve tone, improve muscle movement, and every patient is different, so you always have to have things just selected for you, and not because one thing can be work for another person and have it done to yourself. I always try to include Dr. Wagner here, because he would tell me, no, you can't touch this muscle. Try to avoid putting fat in that muscle. So working with someone who really understands the disease can help us tailor solutions for individual patients. Thank you for your attention.
Thank you. Our next, our final speaker for the day is Dr. Ray Hummel from Quintiles. And Dr. Hummel will be talking on clinical trials readiness and the patient's roles in clinical trials readiness. Thank you, Ray.
Thanks, Dan. I'd like to also thank the FSH Society for being a cornerstone to my family. In addition to being a veterinarian and working at Quintiles for 16 years in clinical trials, I have 2 children with infantile onset FSH. I'd also like to thank Quintiles, who's a sponsor for this talk. When I first talked to the FSH Society, the fact that Quintiles runs clinical trials and runs more clinical trials than any of our competitors, I thought that I would be talking about kind of like the pros and cons of clinical trials. But after talking to June and others, we decided that since we're a little earlier in the stage of clinical trial development with FSH, that we would focus on natural history studies. So that'll be the topic of this. I also fall back to my experience in regulatory affairs, and we'll touch briefly on some regulatory updates that'll be important for patients with FSH and ultimate clinical trial development. So I think the first bullet point we already know, but a couple of things I would just want to kind of provide with you so we understand about where natural history studies come in as kind of the current state of affairs. So some of the clinical research that we face and the hurdles that can delay a care is that the molecular basis for FSHD is not completely worked out. It's a little difficult to define and measure the rate of change in a slowly progressing disease. There is a variability in the disease progression. There's differences in the genetic mode of transmission, so they're not quite all figured out. I think the existence of the various forms adds another layer of complexity, as well as the phenotypes that were discussed earlier. There's actually few patients available or eligible for clinical trials. The variability that's been mentioned before, and some of the preclinical animal model differences that we've seen. Very encouraging, and I think there's some significant progress, but still more needs to be done. So that's kind of where we're at. So I got this off the website. If you look up about clinical trials and tissue donation and things, and I just want to bring a couple of points to this group. One of them says that some of the studies do not require blood or tissue samples, but are natural history studies that monitor a person's FSH over time. So I think what we're coming at this is from a lot of different areas. Other speakers have talked about registries. Some folks, like Dr. Wagner, have mentioned on clinical trials and early preclinical trials. And this talk is going to be just on the natural history study. So what we're basically trying to do is monitor a person's FSHD over time to understand how the disease progresses, realizing all the complexities that we just mentioned on the previous slide. So what are they? In essence, a natural history study should not raise or does not raise ethical concerns where there's no adequate treatment, and the purpose is to gather information. And some of you may remember from your college days or looking up on the web about the Tuskegee study, where a natural history study was done in African American men that had syphilis starting around 1932. And when a treatment became available in 1947, the natural history study still progressed, but they did not give the treatment to the people. So that raises a huge ethical concern about not doing that. So I just want to bring that up because I think it should be a distinction that the natural history study is not involving like a course of a therapy or against a placebo or an active treatment. So just to make kind of a differentiation on that, but also the fact that there are some ethical concerns about studying folks and their disease progression. So if you look at some definitions of natural history studies, I wanted to bring 2 to your attention. One is from the National Cancer Institute, and it said that it just basically follows a group of people over time who have are at the risk of developing a specific medical condition or disease, and that study collects health information to understand how the medical condition or disease develops, and that's ultimately so that how you can treat it. And the definition of natural history, which comes from rare diseases epidemiology, is the natural course of disease from immediately prior to its inception, progresses through the different phases to the point where it's ended and the patient's either cured, or disabled, or died. So these natural history studies, in essence, they track the disease over time, and they identify the demographic, genetic, and environmental, and other variables that correlate with the disease and the outcomes. So some of the examples of natural history studies in MD would be one that's being done in conjunction with Duke University, where they look at clinical features, expression profiling, and quality of life in infantile onset FSHD. And then there's another one on prospective natural history study of progression of subjects with Duchenne, MD. And we've actually talked about that primary outcome measure has been mentioned by previous speakers about the 6-minute walking distance, and that's an important objective measure that's been more and more well-defined, but used typically more in Duchenne. Then there's some older studies that have been mentioned already before, so I won't mention those before, but there have been some other studies that have been done with FSH and continue to do more. So these are very helpful to kind of provide the basis for that, so there is historical precedent. So some of the different tests that I've already mentioned have been mentioned by other speakers, so I won't go into those either, but a couple that are highlighted in red just to bring to your attention would be like the manual muscle testing, maximum voluntary isometric contraction testing, and people have actually had some slides on that before, so you can show you how it's kind of done. And the interesting thing about all of them is the studies can establish reliable and valid measures for the disease, not only the state and the progression, but you can use it as an outcome variable in a clinical trial. So that's kind of like the next step of where we're all headed with this. And it can provide guidelines for determining a sample size and duration of follow-up. And that gives you some details in here about this study. But basically just to tell you that, you basically need this information in order to move forward. So let me just kind of make sure that everybody understands that a registry study, which we talked about before, and we had an excellent example from the speaker from France, is not exactly the same as a natural history study. The registries do include communications to parents, patients, and participants and get information back. They can meet even a post-marketing commitment, like something by a regulatory agency, so either in the US or in Europe. They can compile safety data, it's kind of long-term safety data. And just to make a mention that, so you kind of can connect the dots with me a little here, is Quintiles was actually awarded the National Registry for MD Studies from the Muscular Dystrophy Association. So they've had to, because of limitations in resources and funding, of course, they had to limit it to what they thought was the most severe forms of MD. So Duchenne and Becker's are two of the top ones. It's not yet been on FSH, but there is plans for FSH. Next on that. So just in summary on the natural history studies, there is a specific purpose. It's with the intention of describing that disease, and it's intended to be comprehensive and provide more detailed information than you could get otherwise. And basically the main reason is you want to get all this information together so that you can inform drug development, which Dr. Wagner had mentioned earlier before is where we want to all head. The marketing approvals require a design and the conduct of adequate and well-controlled studies based on a scientific foundation, including the knowledge of the natural history of the disease. And some groups, even like the Duchenne muscular dystrophy, has mentioned that they do not wish to use placebos in clinical trials because it's seen as unfair that if a drug can potentially offer promising treatment. But since you have to compare to see whether it's working or not, you have to have at least some baseline. And that's where potentially a natural history study could be used to be actually, if you will, a surrogate for the placebo arm. Because in general, as you all know, the rare diseases are poorly understood, and it's an important role for the natural history studies in rare disease drug development to facilitate the future, and that comes right from the FDA. So you've seen a similar slide to this with Dr. Wagner, but if you look where we put the natural history study course in here, and this is directly from the FDA, one of the slides that have been used by one of their speakers, I wanted to put in here just to show you that it's extremely important. And it enables both an understanding of the pathophysiology and the mechanism of action because there is a disparity in the difference in phenotypes and the differences between FSHD 1, 2, and the other mechanisms to try to get a handle on how all these complex things fit together. The ultimate aim is to get what's called an IND or an investigational new drug application, and that allows the process forward so that you can use a drug experimentally in people. And then the early phase clinical trial that has been mentioned before would be like phase 1 and phase 2. So phase 1 is typically considered in healthy volunteers, but can be in patients. And then you want to try to see if it works and figure out the right dose in phase 2. And then phase 3 is usually a confirmatory trial, and FDA typically requires 2 large randomized trials to confirm what one said, to confirm it with the other, and then ultimately approval. The adequate and well-controlled studies have some certain requirements as per the Code of Federal Regulations. So they have to have a research goal and an objective and a valid comparison with the control. And it has to be the concurrent strongest control or historical, which is why the Duchenne community decided to try to push for use of a natural history study versus a placebo. You have to have an appropriate selection of subjects, and that requires things like biostatistical analysis, as well as to make sure that the right studies not only will maximize for the benefit of it, but also potentially would be the most that could be helped. You have to have a method of assignment to the treatment and controls and the employment of measures to minimize the bias. A lot of that comes with statistics and physician help. And then the other methods that are there as well. So where's the state of the union for this? Well, my background comes in regulatory affairs as well. I've worked in medical writing, regulatory affairs, and then for about 12 years at Quintiles, I worked in product risk-based investments. There is muscular dystrophy regulatory guidance in the industry. There's none currently for FSHD. There has been some draft guidance that's been promulgated for Duchenne muscular dystrophy and Becker's, and it's been available in Europe. So a concept paper was issued back in 2011, and draft guidance has been available since last year for them. I think it's interesting for FSHD because if you do read that, you'll find out that there's an awful lot of things in there that are applicable for both for FSHD patients as well. So even though it's specific for that disease, or more specific for that, it has many different parallels for that. And I thought that it might not be intuitive for everyone to kind of understand that or even to tease that out. So I wrote a paper that was published in the January Regulatory Affairs, and anybody that's interested, I have a few copies up here. Be glad to share it, or electronically if you don't want to carry it home on the plane. Another thing I think it's interesting for folks here is that the Parent Project Muscular Dystrophy guidance that was mentioned by June on the first day during the early morning hours just came out in June of 2014. If you kind of want to get some of the highlights and how it might affect patients or someone in your own family, I published a paper that came out a couple weeks ago on that, and I'd be glad to share that with you. But the guidance that I'm talking about is basically a selection of natural history that's characterizing the clinical course of Duchenne's muscular dystrophy, including a scientific consensus on tools, instruments, and outcome measures, which is all that we're working on right now for FSH. And the most important thing about this is that since the FDA was started, they have not accepted patient advocacy group information to date. So there's never been one. This is the first one that's ever been done. And the first one that ever did it was in Duchenne muscular dystrophy. And my personal opinion, and this is not on behalf of Quintiles or FSH Society, but my own personal opinion is I think this is great news because there is a lot of information that's been done with FSH, and I think that this could be spearheaded by a patient advocacy group. So this is something that potentially we could all influence individually, and I want to personally be a part of it as well. So it has that, and while though it's not yet formally adopted by the FDA and it's not clear which pieces will or will not be, I think this is really great news. Like I said, it just came out in June of this year, and I think that was part also because a paper that I published in January, I mentioned that one of the biggest concepts from an investment standpoint is that those companies that have FDA guidance and those companies that have more association with the FDA, those products usually have a higher risk of success for getting approved for use in patients. And with no specific guidance, it makes it more riskier. So it's harder for people to invest in it. But as molecular concepts evolve and as gene targets like the DUX4 that you've heard about in the last 2 days are becoming available, I think we're at a really great time now for future investment. And I think these guidances are really helpful. So in summary, I think that natural history studies are needed to enhance our understanding of FSH and its progression. They're part of the study continuum that we ultimately will need to lead to the conduct of clinical trials. They involve some sample taking, so it is possible that you may see blood, tissue, or urine to be asked for, or undergoing a certain diagnostic procedure like an MRI, CT, or ultrasound, or things that you've already heard about yesterday or today. But a registry, just to make sure, is not a natural history study, and it's not a clinical trial investigation. But I think that the FSH Society, as it's a key resource for my family, I think it can be a key resource for everyone in here to identify the ongoing natural history studies, and other studies can also be found at clinicaltrials.gov, which provide an overview of the acceptability for enrollment, and you can see them elsewhere online. The FDA has not issued formal guidance for industry on FSHD, but it has received, though not yet adopted, that draft guidance I mentioned to you from patient advocacy groups like the PPMD, and they advocate on patients with muscular dystrophy. Thank you very much.
Thank you, Dr. Hummel. I wanted to also say I apologize for not crediting Quintiles with sponsorship for this meeting. We're very, very appreciative to have your sponsorship and thrilled. We are a few minutes behind schedule, so how about we take, so we had a half an hour for questions and answers, and then we wanted to move into an interesting experiment. We'd like to do a reversed questions and answers, where all the researchers who are in the room will come up here and then ask the audience questions. So I'd like to maybe take one or two questions now, and then ask all researchers who are still here just to be prepared to come up to the front of the room so that we can get into our next exercise.
So my question is regarding, you address quality of life as one of the outcomes, and are you also addressing the social aspects in your physical therapy, and what are your thoughts on things like recovery therapies? You mentioned like strength training and aerobics and that sort of stuff. What about recovery therapies that are used for like sports injuries and those sports that are not necessarily physical but more social, such as like power soccer?
I am not sure I've heard the term recovery therapy, so I would need a little better understanding of that. But having said that, I personally believe that anything that keeps anyone engaged and occupied is good for their physical and mental well-being. So that's the basis I start with, and that it do no harm. And sometimes it's hard knowing about harm in the long term versus harm in the short term. I mean, we have patients that have been in the Army, who've been athletes, you know, and the question always arises, the training that they had, did that actually keep them stronger longer, or did it eventually hurt them? And I don't think we have the answers for that, unfortunately. And here I'm going to, it's a perfect segue for the registries. So I'm going to put in a plug for the registry that we've had in Rochester. It's been ongoing for 14 years. It includes patients with myotonic dystrophy and FSH dystrophy. And some of the questions that were raised, you know, epidemiologic questions, cancer-related questions, these are not necessarily going to come out of natural history studies, which are, if you're lucky, 3 years, 5 years. No one wants to fund natural history studies of any length, but this is where registries become important. And the other thing I would very briefly say is the CDC is interested in population-based studies so that they don't just come from a clinic or a region, etc. And they have been funding something called the MD StarNet project, which I'm part of in New York State, which is a population-based study. And I think all these efforts are great at giving us the bigger picture of all the people out there with this condition and the impact of the disease and other factors on their lives and progression.
I have a question for Dr. Boheen and one for Dr. Pandya. For Dr. Boheen, I was curious to know if there's any success in muscle transplants from, like, if I have a sibling who is unaffected by FSHD, could that muscle be taken from a family member and used for the facial reconstructions in any way to help? And for Dr. Pandya, I'm wondering if there's any kind of thought to giving a guide for massage therapy. I've had a lot of success in feeling psychologically good as well as therapeutic for the muscle from massage therapy, but I'm concerned about going to just anybody and if there could be a future guide for that as well.
Okay. So in principle, just as I'm on the face transplant team at Hopkins, and the face transplants have become so sophisticated that you can take bone, muscle, skin, fat, nerves, blood vessel, and transplant it from one person to the other. So in principle, you can do that. But if you do, that recipient would have to be on an immunosuppressor, and that's the problem. We've tried various ways to try to make the recipient as chimeric as possible, so we can take bone marrow from the donor and do all kinds of stuff so that there isn't the need for high levels of immunosuppressants, but there's always the long-term risk. So at this stage, I don't think it will be reasonable to take a muscle from a donor for a recipient, mainly for maintaining tone. But if we work out that immunosuppressive aspect and minimize long-term complications, one can see that being feasible. But I would hope that gene therapy would come before we ever get to that point.
In terms of massage, again, I think massage has been shown to be helpful both physically and psychologically in many, many conditions. And again, if it makes you feel good and it does no harm, go for it. The only thing I would say is there's massage and there are massage therapists. And the things that I might worry about is some therapists who believe in massage for athletic folks, and it's a very hard kind of a massage. And I would, if it hurts, be wary of it. If it makes you feel good, go for it.
One more question.
Okay. I have a question to each of the speakers. First of all, thank you very much for presenting to us. Question to Dr. Pandya about if the studies on exercise and FSHD, if any of them adjusted for the severity of the disease, since there's such great variability, is it possible that maybe exercise actually hurts people with severe, infantile onset, advanced FSHD? A question to Dr. Bohin about facial reconstruction surgery. How long is the recovery period usually for surgical procedures, and what are some of the complications that you encountered? And a question for Dr. Hummel about whether it's possible to kickstart natural history studies with a lot of patient data that has been accumulated by their individual physicians. I understand that there's no uniform standard, so it's very noisy data, but maybe it's not complete garbage for the purpose of natural history studies.
Okay. As Dr. Van Engelen said earlier this morning, we tend to study what we can measure and it's easy to study. So swimming does not get studied, or other things don't get studied. Most of the exercise studies, depending on the mode of exercise, get done in people able to do it. So if it's an aerobic exercise or walking on a treadmill, obviously you have to be able to walk on a treadmill for a certain amount of time to be able to be studied. So that's why, unfortunately, most studies get done on a subset of population, and then based on the findings, we sort of have to extrapolate that. But then we are always wary of people that are more affected, making the same recommendations for them, because we truly don't know the exact benefit or harm that we could do in those populations. And I would love for Dr. Engelen, I think, is still in the room, for him to comment on that part.
Okay. So as far as how long does it take for patients to recover from surgical options that I offered, so on the two extreme spectrums of the examples that I gave, a lot of the non-invasive procedures are needle, really no downtime. The minimal surgeries, for example, tightening the eyelid, tightening the lip, can be done under local anesthesia, so you don't need to be put to sleep for it. And the recovery is usually recovering from swelling and bruising. On the other extreme, when we are transferring muscle, the most complicated portion of it is when you have to transplant muscle from one part of the body to the other. Those patients are on the average staying in the hospital for 5 days. And for this particular patient population, putting somebody in bed for 5 days can be a big deal. And so we try to include occupational therapy, physical therapy, whilst they are in the hospital to prolong, speed up their recovery. So you are looking for an outpatient in-office procedure to a hospital stay of about 5 days. That is if there are no complications. Potential complications are the same ones you see with every surgery: bruising, bleeding, infection. That usually is treated medically.
Any kind of irreversible? Anything irreversible?
So the most worrisome irreversible change is if I went to take a muscle from one part of the body and brought it to the other part, and you gained in the face but lost from the donor side. That would be the most potential irreversible. And those are preventable things. When we are taking muscles, we're usually not taking the whole muscle. We are taking, because you can't really bring a big muscle on the face. You're really usually taking a small piece of it. So I haven't really seen a donor side morbidity, but you have to carefully choose the donor side to make sure this patient doesn't have is not going to have a big functional deficit from it. So the donor muscles that we select, we try to make sure that other muscles do the same thing.
I think one more question I'd really like to go on to our next session.
Yeah, I had a question.
Dan, did you want me to just answer that one question about the natural history? Just
Yes,
the last
Okay,
part?
Yeah. Go ahead.
So, based on my knowledge of natural history studies and registries and others, I think there is a high value in trying to mine data to try to put together some information that may be in disparate sources now. So taking, for example, say the French registry, combine it with Western European countries, American data, even Southeast Asian data of people who have FSH, and combine that all together, I find that that would be a high value. The problem is a lot of times to put the data together, it's to put it in a data that can make it comparable. So it's hard sometimes to try to maybe define whether it's all FSHD1 or FSHD2, and there may be different variables, but I think there could be some value in trying to bring that together. Also from the natural history progression, I think there would be a value in trying to assimilate or maybe put together a lot of studies together and try to see if there's something that new could be gleaned from putting all the information or data together. So you would need somebody like maybe a statistician and things like that, and you may be able to get not only descriptive statistics, but there may be something that could be elucidated that having small amounts of data together, you wouldn't be able to find a commonality, whereby is if you have a large enough database. And I think that's the one beauty of having an international, like a registry, versus individual registries the way they are kind of set now. My perspective now is that there's a lot of disparity between all those. So although each one has good ramifications behind it, it may only be limited to how that data was collected, the amount of data, and there may be some differences even in the different populations. Right now I work in biosimilars, which are generics of biologic medicines, and we're finding that there are some differences between, say, folks that live in Southeast Asia, and there's some folks with enzymes and things like that they may metabolize drugs differently, and there's differences and stuff like that. So you have to take into account the geography as well. But I do think that there's a value in that, and I applaud anyone who is working on those type of data gathering collections, because there is sometimes when small amounts of data brought together in larger forms can elucidate different things that could potentially help and speed a cure or find a commonality or a thread of something like that that could be towards that.
Thank you. I'd like to thank our panelists, and please stay here. I'd like to have all the researchers come up to the front of the room who would like to partake in our researchers' questions and answers session. So could I ask Dr. Tapgott, Van Morel, Jones, Wagner, Drs. Emerson and Fitzsimmons, anyone who'd like to come up, Dr. Bellew, any of the presenters from yesterday and today, we'd love it if you would come up. And Dr. Van Engelen, Dr. Kunkel, Dr. Tapgott. We're putting you on the spot. So.
Nice dogs. Thank you. We just need to pull more chairs.
Dr. Jones.
Cozy up, that's all.
Okay. Have we missed anyone? I might ask maybe one of you moderate and just rephrase the questions.
I can start it off.
Sure.
in anticipation for clinical trials, the FDA is very concerned about what are meaningful changes to your life. So maybe we could get a few comments on if we had a drug that had a certain effect, what would be a meaningful change that that drug would have. Say it again.
So,
if you could at least for an initial scan. Oh, sure. Yeah. That's what I'm here for. I said, for me, you know, in the beginning, it was such a rapid progression that just having a plateau to go, here it is, it's going to stop at this point. This is what you have to deal with from this point on. That would mean a lot to know, okay, I don't have to think about what's the next phase, what's the next phase.
Thank you. There's one over here on the right.
can you wait for the microphone? Thank you.
Just any improvement or increase in mobility, I think for all of us is a huge goal.
So by mobility, an improvement in being able to walk. Mm-hmm.
For me, it would be the relatively simple act of being able to get up off the floor. For whatever reason, I found myself on the floor. That would be a really powerful thing to know that I could be able to do that again.
I've spent most of my life pain-free, and I used to argue that it was aching, not pain. I've now moved into the pain phase. And so now I guess my biggest thing looking at my future is mitigation of damage or the rate of loss. Anything that, I'm not looking for a cure, I'm already damaged, but just slowing it down.
Thank you.
For me, the most important thing is the upper body. Legs are very important, but you can locomote artificially. The upper body is what helps us with the activities of daily living, of functioning, of transferring, brushing teeth, combing hair, and general quality of life. So that, to me, would be the most important thing, to see some improvement in upper body.
Thank you.
Do you have any more?
Yeah, how are you? I think the biggest factor would be the ability, a drug or therapy to rebuild skeletal muscle.
That was all very helpful. Thank you.
Got a question. What would be the barriers to enrolling in either a registry or a natural history study? Like, what are some of the barriers why a person would not want to get into that or would not want to spend the time to do that? I'd be curious just to hear what folks would have to say on that. What would keep you from wanting to enroll in a natural history study? So you don't know whether it'd be actually a cure or not, but it might help to elucidate information that might help others down the line. Just
I think the one thing that people with any kind of a disease would have a concern about is how the information could be used against you, whether you're applying for life insurance, health insurance, disability insurance, future job employment prospects, and the like. That would be, if there was one thing that would, if you could be assured that it would be held in confidence and it could not be used at some other point in time. And excuse me, as you all see, when we sign all these consent forms, there's really no way to guarantee that that does not come back to somehow haunt you down the road in some completely unrelated fashion.
Sure.
For me, for the registration, I guess I just thought if I registered at one site, I didn't think about registering somewhere else. You would think they would be connected some way. So I think it was lack of information to know to go and register for the different registries because they serve different purposes, it seems, like what I've learned today.
I think in looking at my family, sometimes they don't understand the importance of it, how important that is. They just don't take the time because they don't understand the relevance. Anybody who's done research or done papers knows it is, but other people sometimes don't.
Yeah.
I think for me, it would be cost. The cost of going to the doctor on a regular basis, or the cost of getting to the center. So the natural history study is at Kennedy Krieger, and if I have to travel there and stay, and the airfare, so that natural history study doesn't come to me, I have to go to it. And I think if we could get the study to go to the patients, rather than the patients having to go to the centers, we could move rapidly on that end. For me, I think that's the biggest obstacle, is just the time and the expense of going to the doctor every 6 months or 1 year, and the fact that it might not be local.
Sure. My background is more in clinical trials, and I do know that that's a concern for all patients as well, that what exactly is covered and what's not, because just being in a clinical trial and getting free care or even access to a free medication, while it can be enticing, if you have to spend a lot of time paying out-of-pocket expenses to travel or to stay somewhere in a hotel and some of the more logistical and granular details, I can appreciate that, Dan.
Having participated in a clinical trial, I could probably talk a fair length about it. It was really a remarkable experience. But what I would highlight to this question, I would say, is since FSH has such an intra-family connection, one of the issues I think we see a lot is concern by extended family members about what one person's participation may mean for the rest of the family, particularly for family members who may not want to be addressing the issue just yet.
The one thing I wanted to make a comment, I think this is where the patient advocacy organizations become so important, is in the natural history studies. Unfortunately, natural history studies are not sexy, and no one wants to fund them, and yet they are the foundation of anything that we will do in terms of clinical trials. Rochester was lucky that in 1990 we were funded for a 3-year natural history study, and we did it. We learned a lot from it, but based on all the other stuff that we have learned over the last 30 years, I think it's important again to do more concurrent natural history studies that can be maybe used for clinical trials going forward if you're not going to use a placebo arm. So again, I cannot say enough about the importance of natural history studies and biomarkers and outcome measures. And I appreciate the costs involved, both of time and money, but I think this is where your participation in terms of time and the patient organization's time, effort in terms of money, I think becomes very helpful.
Limiting things to the face, I would like to know if there was one area that can be improved the most on the face, what would everyone want it to be?
You got your answer there.
Yeah, there you go. Where are the microphones? We have a question in the center.
Excuse me, I wanted to ask a question which is not at all related to my research field, which is molecular biology. But I heard from the people involved in the clinical trial with antioxidant in Montpellier that many patients had sleep disorders. And I was wondering whether this was something that was very common among you.
I have the microphone. I don't know if anybody's ahead of me, but for Dr. Bohin's question about what would we want, I'm on your left side of the room. The question for me regarding what I would want from some feedback from my condition is I get this condition of every so often, every 6 to 8 weeks, eyelashes growing into my eye and poking me. And and I feel it's very uncomfortable, and I have to go to an optometrist or an ophthalmologist who just literally plucks them out of my eye, and then it's instantaneous feeling better. And it happens every 6 to 8 weeks. So I was just wondering, you know, is that something, because of the FSH, that the eyelids are just, the muscles are not, you know, strong enough to be in the eye properly and not get that issue?
Yeah. There's actually an easy solution for that. The muscles that go around the eye, the portion that is close to the eyelid, maintains the posture of the eyelashes. It's called the pre-tarsal, the portion that really is on around the eyelid margin. So if that is weak, the eyelid margin is going to roll down. So it's like an intorsion, and then the eyelashes will be pushing on the eye, on the cornea, and it's irritating. So there are simple surgeries for that, and usually it's you put some sutures to evert, force the eyelid margin to go up, and usually if you see any oculoplastics person, any eyelid surgeon, they can do that for you. It's pretty straightforward.
I had a response to the question someone asked before about more participation in the natural history trials and the expense of going to wherever it is. The concept of regionalization. Now, you're in Rochester, but there are an awful lot of people who can get to New York City a whole lot easier than we can get to Rochester. So if you had a colleague in Manhattan who would collaborate with you, and similarly Boston, you know, there are various, maybe not Worcester, you know, but maybe Boston would be a better draw and reduce the expense and increase the participation.
I guess I have another perspective on natural history. I wonder if one might identify certain subpopulations for natural history where the disease is progressing rapidly, and it might be easier to acquire data there. So perhaps that there was a stratification, adolescent boys, postmenopausal women, just gone into the wheelchair, certain kind of acceleration of weakness. That gave me a rationale, where I felt that there was a faster reaction to the data. So that's.
Dan, that's a great point, because I think as we try to characterize the different subpopulations within FSH, not just, you know, the FSH1 or 2 or infantile onset, but as we come up with more and more terms, I think as we get that more defining, I think we can prioritize maybe those more vulnerable populations or the faster progressing populations, and should probably rightly identify and prioritize those higher to put our resources behind them as well as capital.
Your question about sleeping, I don't know if you call it a sleep disorder necessarily, but I do not sleep 8 hours a day. But there's like extenuating circumstances. So I wake up every morning at like 5:30 to talk to him in Australia, take a nap, then I get up for work. But I'm also one that I don't go to bed at like a normal, reasonable hour. So even though I'm waking up at 5:30, I'll go to bed at 11. Or if there's something where I know I have to get up early in the morning, I just don't go to bed, because for me, it's too much effort to get into bed, sleep for a couple hours, and then go through the whole process of sitting up and getting up to get out of bed. It's easier for me to just stay up.
I wanted to give another answer about sleeping. Dr. Sacconi said we must get apart the things due to FSHD and things due to aging, because most of us are adults or aging adults. And I think that when you get old, you don't sleep as well as when you're young. So maybe if many FSHD patients complain about sleeping, it might be only due to old age.
I have an answer to an earlier question in the reverse, not the obstacles to volunteering. I would volunteer for anything, and I think we have a huge population out here. If there's any way to harness the energy in our community, I would like to see a focus there. We're limited on resources, but we have a huge population. How many people would like to volunteer to move this thing forward?
Thanks. Can I ask another question? Could you raise your hand or just yell out if you have a genetic diagnosis of FSHD2? Is there anyone in the room who is FSHD2? One.
Sorry.
No, a molecular genetic diagnosis.
Right now, the availability of commercial testing is very limited. There's only one lab that I know of, and the test is almost $3,000, and mostly not covered by insurance. So I presume I'm FSHD2 because I'm not FSHD1, but have all the phenotype. So I think when there are more labs that do the test, the price will come down, and then we can have that. It relates also to another question. I went years ago to register in the Rochester registry, but I didn't have a genetic diagnosis, and that was a prerequisite for that. So I don't know now if I could go back to the registry. But again, I don't have a genetic diagnosis. I presume it's FSHD2, but it may be FSHD3 or 4 or something we haven't discovered yet.
Is there anyone in the room who has a genetic diagnosis of FSHD2? You do.
My family members participated in a study, a research study, and by virtue of that, there was identification of a marker, which has now become available clinically. So they're at the point of having one of the family members confirmed by that clinical test, which would then be of value to other family members who don't know if they're affected or not, for the price of probably a couple of $100s, because they can narrow down to that particular marker rather than looking for broad, who knows what, might be an abnormality. So there's potential, but that came as a result of a study, and I'm not sure how many of those studies are being done.
I was diagnosed originally as a gray, but they decided that between Dr. Tawil and Dr. Van Morrow from Leiden, whatever, anyhow, sorry. And then they decided that I did have FSHD, but it was not coming from DUX4 like everyone else's was. So that's, that's all I know at this point, is that I was diagnosed as having it, but it's not coming from DUX4.
There's somebody over there, Charles? Down there?
Yes, I wanted to comment on this. It would be very surprising that DUX4 be not involved. So if it was the case, we would all be extremely interested, so I don't know.
I can't comment on this.
Yeah.
I can't comment because I don't know individual data from all the individuals that are being tested in Leiden. So I really don't know. I need to check into the details and get Dr. Tawil involved in that.
Yeah, I'm curious as to the blood that was drawn yesterday. Is that going to be tested and characterized, 1 or 2, or what are they?
So the purpose of the study yesterday, and it's also available today at 2 o'clock in the coat room, is part of the effort to understand divergent phenotypes within the same family. So people who have the same allele size, but have very different severities. And so, one of the reasons that it may be, a parent was mosaic. One of the reasons may be that they also have the gene for FSHD2, but there are probably many different genes that contribute to the severity, to try to get a handle on that. So yes, so DNA will be made from the blood, and then we'll be looking for other mutations or modifiers of the disease.
Will we be made aware? Are we one or two? If we donated, will we be made aware at least? Are we 1, 2, or both?
Well, the consent form that you signed from University of Massachusetts actually said that you would not be. That was a stipulation of that particular investigational review board decision. My guess is that if you'd like to be, that those results could be sent to your physician, who would discuss them with you.
Catherine? I know this is extremely rare, but as I know there's someone in the room who might be able to describe her family's experience about what to look out for in the rare, and I emphasize rare but real, onset of a retinal problem in order for it to be treated, I was wondering whether Nancy might have some comments. Sorry, I just wondered if you would like to comment on the way that your son's retinal condition presented before you were aware of the muscle problem, and therefore what to look out for.
Ty was 17 and came home from school and said that he hadn't been able to see out of his left eye for 4 days. So it's a typical boy, thinking it was going to go away. We went a whole year before I accidentally stumbled across somebody asking a question or stating that their son was being tested for FSHD. I had no idea what that was, and I Googled it. So I looked that up, and all of the symptoms fit my child. So looking back, it was low muscle tone as a baby. He had severe allergies and asthma, seizures, not to the point of having to be medicated, speech delay, and as he went into puberty, he had the winging.
But in terms of the eye condition, which was treatable, I guess there's a message there which is the important message. This was before the muscle disease was recognized, although in retrospect it was obviously there, and it was the Coates disease, in inverted commas, that was diagnosed first. So I guess your perspective on what to look out for from that perspective.
I would highly encourage anybody that, and I know that the retinal issues can happen at any time, but I would highly encourage everybody to have their kids checked with an ophthalmologist yearly and have their eyes dilated, because if they're not dilated, they're not going to be able to see as well to see if there's any retinal changes. He does have issues with his other eye, but it's not diagnosed as Coates disease in that eye. There's retinal involvement, but no
exudates.
Correct. So just the exudates and the blindness.
And
in
I
that
suppose
one
the
eye.
point is that as soon as there's a suspicion, because it's eminently treatable early, that was the point.
Absolutely, absolutely. I would suggest if you have that diagnosis of FSHD, or you have it and you suspect that your kids may, absolutely get their eyes checked as often as you can, because it can be, that blindness can be prevented if it's caught at an early stage, which Ty's was not. Is that what you're asking, Robin?
Yes.
Okay.
Just so that to get that message.
Absolutely.
Across.
Highly important. Highly.
I would like to add to that, because I twice a year go to my optometrist, and he has a machine, I don't know the name of it, but it does take a photo of the back of the eye and the macula. And I was diagnosed with exudative retinitis 2 years ago, and they had me coming back to a specialist for a year and a half as they watched to make sure whether or not it was going to clear up or whether it was going to become something of an issue to have to treat. But it is treatable if it is caught, and to have an exam is painless and should be done on a regular basis for even adults. Thank you. Here we go, over here.
I'm starting to believe that maybe the retinal issues are not as rare as we think. And maybe that's worth some study. I had a retinal detachment last year as well. So I'm wondering if it's maybe something that we ought to look at in some way to see what's going on. As a grown-up man, I didn't wait 4 days. I only waited 1. Yeah, right. So but I still, you know, it's going to go away. So I think that's something maybe we, in our work, we should consider, seeing if there's some correlation beyond Coates disease specifically.
And I had an eye question too. My mother had a retinal detachment, but my son has recurrent viral conjunctivitis, and somebody yesterday mentioned conjunctivitis was more common, but I didn't know if that was bacterial, viral, or both.
I'm a neurologist, so I don't want to get into too much detail, but in terms of the eye, you know, sleeping with eyes open, and it's obviously more exposed. The cornea is more exposed, and it's not surprising that it's there. The conjunctiva and cornea may be more vulnerable. But as I say, I'm not an ophthalmologist, although I'm the myology half of a collaboration which has been going on for a long time on the retinal associations, which I suspected a long time ago. So yes, if in terms of coordinating questions about how common this is, I'd be very pleased to hear from people.
I have a question for the group. Can I get a show of hands? How many people routinely have in the past or currently are involved in some kind of a pool or water program? 1, 2, 3, 4, 5, 6, 7. How many in any kind of a regular physical activity or exercise program? Okay. And for the others, is it an issue of cost, finding the right facility, the right people, or the concern of the care providers about whether it's helpful or harmful? I think there's an answer there.
I'm so glad you asked this question. I was hoping that you guys would talk about this. I was hoping you would ask this question. I think that there are a lot of barriers for people to become physically active. Even able-bodied people often have barriers in becoming, you know, consistently physically active. So I think for us there are more challenges. And I know for me, one of the challenges that I had when I regularly was exercising was a feeling of shakiness and weakness that came after the exercise and lasted anywhere from 10 or 15 minutes to an hour. And when you think about just the effort of like getting yourself ready to go to the gym, right? And then going to the gym and then getting there and then doing the actual exercise and then having to spend an entire hour basically recovering before you can feel comfortable, like in my case, going to work, you know, and walking up and down the hospital hallways just is like too much of a commitment. And so I find myself just not doing it, which is totally not good. And I would love to hear other people's experiences and hear, you know, if you guys are going to do sort of a response to your first study with the exercise and the effectiveness, I would love to know, like, was there anyone that dropped out of the study and why they dropped out? And then, you know, if you're planning on doing a follow-up with them to see if anyone had barriers that came up.
I think there's another hand in the back there.
I could answer. I totally agree with her. I have 5 steps up to the first floor, 19 steps up to my second floor where I live. I go up and down 3 times a day. It takes me 5 minutes or so to get up those stairs. I don't have time to go to the gym and keep my normal active life, and I'm active all day long.
I used to swim every day, 7 days a week, from 1983 to 1996, 40 minutes a day. As the disease progressed, and I loved the water, I loved the exercise. As the disease progressed, it got more and more difficult to find a pool to get in and out of. And then after that, having the lift issue resolved, it then becomes more difficult to get dressed and undressed at the pool. So it's logistics. So if Sue and I want to go for a swim, it's a 4.5 hour ordeal. And then the other aspect is the physical therapy. I felt that 6 or 8 weeks of outpatient was very beneficial, but it was something that I would not integrate long term. And physical therapists weren't always aware of the lifestyle. So that's my 2 cents.
In our situation, we're from South Carolina, and there's a very large lack of knowledge for practitioners there. We were unable to find a physical therapist who even understood the disease or even had heard of it. So we struggled there. We struggled finding a surgeon to do the scapular fixation. So we're dealing with a lack of knowledge with practitioners. I think that is the biggest problem, especially in the South. It's very difficult to travel up here to where all this wonderful knowledge is and partake in that. So if there's any way that knowledge could be spread, that would be wonderful.
Again, when my son was diagnosed and we had a PT eval, the PT said, don't ever lift anything over 5 pounds. So that being said, there's so much, I'm not going to say ignorance, but a lot of doctors and PTs have no idea. And we left that visit and I said, do what you want. It's use it or lose it. Or if you work too hard, you're going to lose it quicker. There's nothing really definitive right now, is there? About exercise and weight training or how hard to push yourself. I get don't push yourself past exhaustion, but I'm not going to tell my 19-year-old kid don't lift over 5 pounds either.
There is a Cochrane review on exercise in muscle diseases. You can use that. And in the Netherlands, the patient advocacy group sent out mailings and also leaflets for the patients to bring to their doctor and PTs. So, because a lot of PTs think don't race with a broken car. So with a muscle disease, you do not use your muscles because in the past in the MDX mouse it was shown that training was not beneficial in the MDX mouse. But so I think the best evidence is the Cochrane review on exercise in muscle diseases.
I found it as the difficulty in just getting out of bed. I can get exhausted. You know, just getting into my wheelchair can be exhausting. So, and then the thought of going to a physical therapist or an occupational therapist, their goal was always to get you better. You know, like I was an athlete, an injured athlete that they wanted to heal, and trying to explain that no, I'm trying to find new ways of doing things. I'm not going to heal. I always kept hearing that. I tried physical therapy about 5 times, and there's always that. I felt they were looking at me as an athlete they wanted to heal, and trying to get that understanding that no, I'm not going to heal. How can I do something differently?
I have also a comment about the exercise. I just think I'm not sure I'm at a roadblock. I'm not sure what modality would be appropriate anymore because I'm getting different responses to my body. For instance, two particular instances, I was swimming and I used fins for buoyancy and to help me glide through the water easily, which is easier on my upper body. But with drop foot, now I have 2 AFOs, and I'm not sure if the fins are a disadvantage because it just emphasizes the position of drop foot. So that was one reason, in my own mind, I'm just thinking, and no one could answer that as far as my PTs or my personal trainers. And the other thing was I was cycling, my back was giving me, I was a big cyclist prior to the AFOs, but I don't trust myself clipping in and out of my bike anymore. So I was using a recumbent bike, boring, didn't get the cardiovascular benefit, so I went to the elliptical. Now, there was a knee issue that came up, such that I thought I did something really damaging. I couldn't put any pressure, had an MRI, saw an orthopedist, nothing wrong with the knee, but he can't tell me what is wrong with the knee, but there's constant pain. So I just don't know who to go to and what to do.
I just have a comment on the woman over here who was looking for some place to go for exercise. Well, for the last 10 months, I joined an organization that is just for women, and there's only 4 clients in the studio at a time, and I, for 8 months, had a one-on-one physical therapist with me. I don't know if I can mention the name of the organization or the gym. I will anyway. In Shape for Women. So I joined that for the reason to build up my muscles. So I went from I couldn't even walk on the treadmill. I actually fell on the treadmill the first day it was there. And I was mortified. So I went from not able to walk on the treadmill to walking 31 minutes, 3 times a week. And then I went from lifting, doing elastic bands. I couldn't even do the elastic bands from the rotation of my shoulders to now doing it at 20 rotations on each arm. And that's over a 10-month period. I recently fractured my back, so I haven't been to the gym in 2 months, but I'm anxious to go back. So then I went from lifting only 2-pound weights this way to 8 pounds on each arm. Yeah, so there was a benefit, and now my legs, my muscles on my legs are very strong. My back is my weakest, so I do rowing in that gym. So it's 25 minutes muscle strengthening and 25 minutes on the treadmill to 30 minutes. So maybe there is some benefit there.
We have time for a couple more questions, and then we should wrap up. Dr. Emerson?
It's just evident that the relationship between patients, their families, and the therapeutic and research community, that partnership is critical to your daily lives as well as therapeutic development. And I hear all kinds of really interesting, important things coming back in the response to these questions, like what should we do more retinal work? Why don't we have good delivery systems for conveying information to physical therapists? Why don't we have more medical centers? Is there some way that we can, how do you feel you're communicating this information back? Is there a way you guys can organize it in some way, these particular concerns that can be distilled and put forth in some organized way, so we can not just hear these things, but have you sort of distill this down into some way that we can actually have an action plan to go forward and see if the society can collate what you're saying in some way that you can agree on as these are the priorities that we need to be thinking about.
Can I elaborate on that a little bit? Because we did such an enterprise in Holland, starting a dialogue. I think this is an excellent start then. And the FSH Society could start a dialogue with patients not only today, but more systematically to identify the themes that are important from not only by patients, but in the dialogue between patients, researchers, and doctors. And based on that, we published this in 2012, the research agenda as a result of a dialogue between patients and doctors. And it the result was unexpected, at least by us. So I totally agree with you that this can be the start of a longer duration, and FSH society can then have also an agenda which is really, I think, unique in the world.
I think for us, we had a different strategies, because I speak on behalf of my husband, and back home there are different issues. There are cost implications, their facilities are not there, and also the infrastructure. Like at one point he decided to be walking, but falling is quite often, so he can't keep on walking, and that is a big challenge for us. Then when we think of doing it at home, the cost implications of getting maybe the treadmills and all that has been a hindrance. And I think also I would also want to share with my sister there that this information is also not well spread to other different nations. It was quite a challenge also coming here, because we needed to get this information, and that is why we decided to sacrifice and come and meet different people and from different nations, and we are so grateful. We also have a question. We were just wondering with my husband whether there are other hospitals maybe in Africa, or to be specific in Kenya, where you collaborate with, where maybe we can go and do the testing, because we have a 16-year-old son and a 10-year-old, and we are just wondering if we could get a chance of taking them to be tested so that we can know quite early. Thank you so much.
A question out on the right.
While I fully appreciate the fact that everybody's an individual and has different reactions and difficulties, over the last couple of days, I've heard a number of suggestions or comments by people in the room as to what has helped them in particular. And I think it would be very worthwhile if the society, in the questionnaire for follow-up on this program, could ask us, do we have something that we can share with the others that has been particularly helpful? In the session yesterday afternoon, there was one person who said he was falling in the office and gaining weight. He changed his diet, he added more protein and exercise, he lost pounds, and he wasn't falling anymore. There are a lot of different activities people learn to do themselves, whether it's walking upstairs or others. But if you've had something that's been successful, and it could be a brace for your leg, it could be a wheelchair, it could be a lot of different things, I think it would be very worthwhile to share that. And conversely, I think it would also be very worthwhile to share if you've done something and you've had a very negative reaction to it. That would be useful information.
Is there a social media website that would be useful for?
Yes. There are Yahoo and Facebook.
Is that a good venue for this kind of discussion? Okay, excellent.
30,000 posts on it.
Wonderful.
Online support groups for FSH, I know 3 of them. Can't hear you. I just said there's 3 online support groups through Facebook that I'm part of that all offer helpful suggestions.
6? Okay. All right. You want me to repeat it again? No. I just recently joined 3 different online support groups through Facebook that are all for strictly FSHD patients, and they're very helpful and very affirming, and we share lots of helpful hints. So they're out there. I can give you the names of them if anybody wants them. FSH Today, FSH Friends, and Living with FSH.
And I just wanted to make a comment too, because my children also been offered use of those sites. And one of the things nice for teenagers is that they are just specific to folks with FSH. So it's not like everybody's looking at it with that type of microscope, if you will. And I think that confidentiality may yield to a little more sharing and things like that. So I applaud that. And FSH can always be called if there is some concern about trying to get a hold of on thing or something like that. June's been fantastic with our family on that.
Yes, in order to get on those sites, because they're protected for our sake, so that if you Google, some of them will be public, but most of them will be private, so you can feel free to discuss your issues. You need to be a Facebook member, and then you need to be invited in. Now, that's not because it's cliquey. Anybody can come in who has FSH. We just want to keep out voyeurs and people who don't have good intentions. So you need to be Facebook if you want to be on those sites, and contact the FSH Society, who will arrange to have someone invite you in, and then you just can be part of the group, and it's very enjoyable.
So I was trying to get more involved in the clinicaltrials.gov, and I'm over here in the back right. Hey, okay. So back left, I guess. Well, since half of you guys are in Europe or wherever you guys are, it's very difficult to get to Europe from Atlanta, Georgia. So is it possible to have facilities either where you are, Wagner, and in Seattle and Rochester, to have us be a part of those trials and then send the information over to Europe?
If I could rephrase your question, I think you're asking whether if there's a clinical trial in Europe, whether you could participate in it in the U.S. And that would be dependent on the principal investigator in Europe. So my guess is that you had a single site trial. Was your exercise trial just yours?
No, 9 sites.
9 sites. Okay. Well, then you're just going to have a site in the U.S.
Okay. Well, I think we're just about there on time. So I want to thank our scientists for joining us, and I want to thank the audience as well. And thank you to our panel, and thank you to our audience. It's now 10 after 1, so we'll head to lunch at this point. And we have breakout sessions starting at 2 o'clock, so we should go to lunch and then consider going to the sessions. And thank you, everyone. Thank you. Hey.